My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're very pleased today to have this event where we're releasing the June issue of the journal focused on pursuing health equity. It's a terrific topic, an important topic, and an excellent collection of papers that I think will further our understanding of the issue and our efforts to achieve equity, which after all is the goal. I note that equity is one of the dimensions of healthcare quality as defined by the Institute of Medicine, now the National Academy of Medicine. But just making it an element of quality or using it as part of the definition doesn't really tell us much. After all, patient-centeredness is also part of the definition of quality, and you all know how well we're doing on that. That was a joke. You're supposed to laugh. So the question is not just do we view equity as a critical element of healthcare quality, but how do we understand the obligations of the healthcare sector, which is our audience for our journal, in achieving this critical goal. And as we put together this issue, we found two dimensions that are related, but they are somewhat separate. And I think our effort in this issue is to try to bring the two a little bit closer together. So part of equity, of course, is inside the healthcare system and looking at practices and policies and biases within healthcare. But as a tremendous amount of work, including by many of the authors in this issue, has shown us, inequities in healthcare have their roots well outside of the healthcare sector. And so as we move to payment and accountability models in healthcare that are designed for population health, for total cost of care, other things that capture what it takes to achieve health, the healthcare sector is challenged not only to improve inside of itself, but also to figure out how to relate to the broader social sector where so much of what determines people's health happens. And this is something we've been talking about and leaders in healthcare have been talking about for a long time, but talking about it and making it happen are two really quite different things. And so in this issue, we not only are documenting and exploring the nature of inequities within healthcare and efforts within the healthcare sector to address those inequities, but also efforts by the healthcare sector to be engaged in a broader social discussion about the determinants of health that are the roots of so many of the inequities we observe today. And that's how we've structured the journal issue. It's how we've structured the discussion today. An issue like this takes a tremendous amount of work. I want to acknowledge the funders. We had a nice collection of funders who are dedicated to this issue, and without their support, it simply wouldn't have been possible to put it together. There, you see them up on the screen: the Kresge Foundation, the California Endowment, the Aetna Foundation, the Colorado Health Foundation, the Episcopal Health Foundation, the Robert Wood Johnson Foundation. And so I want to acknowledge what they've done to make this possible. I'd also note for you that in this issue, as we have in many of our theme issues, we have a data graphic. We hope you'll take a look that explores various dimensions of equity, drawing upon data both within the journal issue as well as from outside of the issue. As we go into the program today, we're going to begin with a conversation with our two theme advisors. When we have a thematic issue, we ask people who are expert in the field to help us craft the issue, to review the papers, to help select the papers, and really provide the intellectual leadership that brings the issue together. And so we're going to begin this morning with a broader conversation to try to situate the discussion we're having today in a bit of history. We'll move then to efforts to pursue health equity, looking at the social determinants of health, and after a break, we'll come back and look at some of the efforts within the healthcare sector, both the evidence of inequities, some of which are narrowing and some of which are broadening, as well as efforts to address those inequities. And so as I begin, I want to welcome Joe Betancourt, Associate Professor of Medicine at the Harvard Medical School, founder and director of the Disparities Solutions Center, there's a paper in the issue that discusses some of the lessons from that center, and we'll be talking about that in a moment. Paula Braveman, Professor of Family and Community Medicine and Director of the Center on Social Disparities in Health at the University of California, San Francisco. So to kick us off, I'm going to sit down. We're going to have a little bit more of a discussion style as I ask them to set the stage for the discussion, and then we will go into our more typical presentations of the papers. So as I moved here, I'm going to start with Paula and ask you to situate, as I said, our discussion in the context of history. When I was first introduced to this topic, we tend to use the terms like health disparities. Now we talk about equity. Tell us a little bit about that evolution and what the implications of that evolution in language are.
Well, Alan, I feel that you kind of set me up for an answer to this with the remarks that you just made. The movement to address health disparities in its beginnings focused essentially on racial and ethnic differences in health care. The move from the disparities frame to equity meant broadening the frame and saying that we are concerned, we continue our concern with racial and ethnic disparities, but we also are concerned about disparities by other dimensions, other marginalized and excluded groups. So by socioeconomic status, by gender, by disability status, by LGBTQ status, et cetera. And that it's beyond health care. So health care is one of many determinants of health. It's a very important one, but it's only one. And the equity frame really meant saying we're going to look at all of the determinants of health. We're going to look at health care, but also those determinants apart from health care, the so-called social determinants of health that play such an important role in health. I think the other implication of going from the disparities frame to the equity frame is that we're being explicit about values. And a lot of the values issues were implicit in movement around, as it began around health disparities. But by going to the equity banner, we're saying that this is about values, it's about fairness, and it's about justice, and we're ready to be explicit about that. So I'd say those are the big differences that I see. Oh, but one other comment. This does not mean that we throw out all the work on disparities or the focus on disparities. We need both. These concepts are a set, because how is it that we monitor our progress toward greater equity? By measuring how health disparities, by these various dimensions, how they change over time. So.
Yeah, no, that's very interesting. Thank you all for being here, by the way. Really appreciate your time and commitment to this important topic. I agree fully, and would just add, you know, the Heckler report in the 80s, that was the first report on minority health, and that was a term that even predated, to your point, the term disparities. IOM, unequal treatment, kind of puts it on the map. Quality chasm then positions equity as a key pillar of quality. So this evolution is very important, but I think it's important to highlight the tension that you I think began to allude to. There's a lot of people who've been doing this work for a long time who, because words matter, in some ways feel like there is, you know, a bit of a whitewashing of this topic and the depth and difficulty and long-standing challenges that have particularly emerged from the research on racial ethnic disparities in communities of color. That this, you know, I just want to name this tension as we move to these terms. There's people who feel like, well, are we then forgetting? Are we not tackling the hard issues? Are we not kind of confronting the real challenges and softening the terms to get more people aligned? And I think as we try to move this issue, we need to choose our words carefully and define what these words mean, because they mean a lot of different things to different people. Certainly this movement in equity is taken an approach to broaden the umbrella and a lot more than just racial and ethnic differences in outcomes or quality for other groups as well. So it's an evolving term, but it's something that I think requires a lot of attention, both in the healthcare community, but also in the researcher and policy community.
So maybe this is a tough question for someone based in California and someone in Massachusetts, but when you start broadening this out into a value discussion, and you start turning it into you start building the relationships out to social issues, it just seems very easy for equity to become a political issue, to become more partisan, because you're thinking, okay, how do we address these? What's the role of government? And some of that value conflict. So how do we continue to pursue an equity agenda while putting the value issues up front but not making it partisan?
It's tough. I said a couple of minutes ago, I said that equity meant fairness and justice. But fairness and justice mean very different things to different people. I've recently done some work with staff at the Robert Wood Johnson Foundation to try to develop a definition of equity that was less ambiguous than many of the existing definitions have been. And so we've added to the fairness and justice, we've added that it requires, pursuing health equity requires removing obstacles to health. Obstacles to health such as poverty, discrimination, and their consequences. So trying to call out these concrete areas that need to be addressed. So fairness and justice mean very different things to different people. And in addition, you can be pursuing these goals, even going after poverty and discrimination at very different paces and with different levels of energy and commitment. You know, some communications experts several years ago had advised me not to use the term, we want to see a level playing field, that was like waving a red flag at conservative people because it raised the specter of the R word, the redistribution. And so I think some people have tried to avoid using terms that inflame partisan feelings. I think another thing that we can do to avoid alienating people who actually might have been open, focusing on kids can be a way of doing that. It's very hard to blame kids for not having done enough to take care of their own health. And I also think that always addressing the economic implications, so addressing the values, but at the same time addressing the economic implications. So very, very big business groups have energetically endorsed universal pre-K with the argument that was essential for creating a healthy and therefore productive workforce in the future. But then I'd like to say there are these things that we can do to try to reach out beyond the choir, but I do think that if someone really believes that there is no role for government intervention in seeing that justice is served, I don't think we should be diluting our message in order to go after their approval, because we're never going to get it.
As a research journal, I'm going to hold my research question for the end because that's where I want to end. But let me turn to Joe. You started the Disparity Solutions Center. What motivated it? What was the gap you were trying to fill when that came to your mind?
Well, you know, there's no doubt that this is a very, very complex problem that ranges from root causes that emerge in the community to what happens in an exam room. And you know, my personal experiences really emerged from growing up originally from Puerto Rico in a bilingual, bicultural home, serving as an interpreter for my grandmother, really seeing the complete span of these issues across our family's experience. And I think as I got very interested in trying to represent those voices that we don't ordinarily hear at tables like this or venues like this, disparities became my professional pursuit and interest. I think for me, I had the good pleasure of sitting on the Institute of Medicine committee that released Unequal Treatment. And I guess when we emerged from that discussion, we acknowledged that disparities are due to social determinants and access to care, but that healthcare matters, and that there's no doubt that as we develop new technologies and therapeutics and do all this work, we need to have our own house in order within the healthcare system. And what really struck me was, as we went out and were trying to do events like this after the IOM and really share what we had found, in academic circles you saw people who said, yes, we know it, we've seen the literature, but if you went to end users, leaders in health plans, hospitals, health centers, the general sense is, I kind of get their disparities. I'm pretty sure they're just due to social determinants and access. So if we just level that playing field, these things would go away. I know the IOM says there's some other stuff here, but I'm really not sure, how this relates directly to me and what I could do about it. And so understanding that this is a very broad problem, the part that I chose to really focus on was disparities in healthcare. And so the Disparity Solutions Center really emerged, I think, from a collective set of personal, but I would say community inpatients about a lot of wonderful researchers defining the problem ad infinitum, but very little translation between these problems and solutions on the ground with operating healthcare delivery systems. And so that's the gap we try to fill. We try to translate research into policy and practice. We feel like the move towards solutions is long overdue, and we found enough problems, and we keep finding problems, and I think it's important to keep finding problems. I just challenge the research community to not find 5 complexities of the same problem, but instead think about how we could solve the problems that we have. That's the gap that we try to fill, and we do it in a variety of ways that I'm happy to share in a bit.
Yeah, so in your paper you describe the key barriers as leadership buy-in and priority setting. And even though no one laughed at my opening joke about the definition of quality, I can easily imagine a busy hospital administrator or executive in any health-serving organization looking at these dimensions of quality and saying, yes, even if you've convinced them that it's not all outside their walls, how do you make it a priority inside the walls?
Well, I think if you look at this issue, equity, I think, as you referenced, there's several areas within the quality chasm that have lagged behind. So let's hold safety up for a moment. I think the safety movement, if we track it, if To Err is Human comes out, we have a lot of, I think, action, a lot of discomfort. There's leadership that steps in. There's a series of carrots and sticks, transparency, a whole mechanism that's built out, organizations that then come into the fold, IHI and others really driving the safety agenda. And I think change is hard, there's no doubt, for anything we do. But where I feel like this area has lagged behind is there's no, and what our paper identifies from our work with over 300 and some odd leaders over now 11 years, is that the tactics to identify and address disparities in care are not unlike basic tactics around quality or safety. It is about collecting data. It is about monitoring and developing interventions. The challenge is that for many, conversations around equity are the third rail. The not me phenomenon is very powerful. There are other issues that are safer, and no pun intended, to tackle, and I think that's what's really challenged people doing this work, is that it's not for lack of tactic, it's for lack of leadership buy-in, organizational culture, execution, and I would say, perhaps equally importantly, an external policy context that holds people accountable for their performance, as well as provides some transparency and some set of carrots that really drives the healthcare system, as we've done with safety, to more equitable care. I'll end by saying that I think we could make, and we've been making that argument very effectively, as we begin to tie the root causes of disparities to quality, safety, cost, and value, and make the point that these issues that lead to disparities, to your point, don't just impact minority populations, they impact all people, no matter what their stripe, just to varying degrees.
So I want to use that as a point of departure for sort of the evidence question in this field, which is that as we broaden out our understanding, as Paula said at the outset, of the origins of inequities, if you're trying to move the evidence forward, we could become we could decide that we need to know everything about education, everything about employment, everything about housing, everything about community functioning, criminal justice, because it's all health, and then we're sort of trying to take on the whole world. And Joe, as you said, for any individual person, they need to find an action point, and I think your point about the lack of an external policy context that demands performance is key. We can't possibly hold the health sector accountable for all of those social systems that affect people's health. So from a research policy perspective, understanding this growing awareness of the roots of inequities, how do we turn that into a research policy agenda that has meaning?
Well, I think that we, at the risk of becoming so broad that we're not making a contribution anywhere, the research agenda in health has to be driven by thinking about what influences health and thinking about as Jeffrey Rose had said, the causes of the causes, not just the cause that's right here, but what about what caused that? And I think I think that should be a high priority for funding in the area of health research. I think that to do that, there needs to be an investment in methodologic development, because it is very, very difficult to study the connection between the so-called upstream or root causes of health and the health outcomes that often occur decades and sometimes generations later. So that if you're interested in the upstream causes of health disparities, you're talking about the existence of these very long and complicated causal chains that are composed of many, many, many different steps. And at each step, just to make things worse for a researcher, at each step there's a possibility of interactions with multiple variables. So it's really tough, but I think that there is room for further methodologic development to give us some tools, because the RCT is not going to solve all of our problems. There's a place for it, and I think that when we can't do an RCT, it behooves us to think about trying to approximate it. To go through the steps in thinking about isolating what could be most important. I think that if we, maybe I'm not answering the question of how it is that you narrow the agenda enough, that I'm calling for the broadening of the agenda, that if one looks at what are, some of the most crucial areas with health impact, what about early childhood education and development? What about what works for K through 12? An investment in making those work and looking at the tie-in with health, I think could have huge implications. So at times, I think we're talking about really broadening it to a point that most people will probably consider way too much. But sometimes I've wondered whether an investment in research to answer the question, how do you create political will for pursuing health equity? That's something that could really move things forward, but obviously is not going to happen inside the health sector. So just one more thing I wanted to say about this, that I think that we have to continue to document disparities. Unfortunately, that's never going to go away, the need to do that. We have to continue to try to understand what creates the disparities and what creates resilience. But we do need more investment in testing bold interventions. And the kinds of interventions that you're not going to be able to study with an RCT. But that doesn't let us off the hook from being rigorous. The fact that you couldn't do an RCT, that there are ways to study things rigorously, and we should look at what are the most important questions and study those questions with the best methods to examine those questions. Not say, well, I can't run an RCT on this, so I'm just not going to pay any attention. But they need to be bold interventions and in different settings, and I don't think that that's happened yet.
Sure.
Yeah, I would just add. I mean, I think to me, as a practitioner and somebody who kind of engages in policy, there's absolutely zero doubt the impact of social needs and social determinants on health. There's little to no doubt around the impact of lack of access to quality and outcomes. There's little doubt about the disparities in caregiving that occurs. So the question then becomes, how do we create an agenda that allows us to move forward, particularly around the bigger question, around the social determinants. I think we've seen countless wonderful foundation-funded interventions that have done great, proved amazing, developed, rolled out incredible outcomes, but there's no funding stream to sustain it. Why? Because the funding mechanism, the way we funded healthcare, has not supported a continuance of navigators or community health workers. Why? Because there's multiple stakeholders, who gets the ROI, there's all these complexities here. And so I think we've seen all too many of these interventions fall by the wayside. So if I were to summarize, I'd say, a research agenda that focuses more on solutions and action is important. A research agenda that focuses on solutions and actions that are practical and actionable. By that I mean they're not a solution that is just going to go by the wayside because it cannot be sustained through the current policy context is critical. And then finally, I would say a research agenda that tries to identify win-wins. The win-win of not just one constituency being a winner, not just it be government funded, not it just be within an academic health center, but something that could really thread the needle between public, private, academia, and something that emerges out there that allows for multiple winners. I think that's research that could be transformational.
Well, I want to thank you both, not just for this great kickoff to the session, but also for all that you did to make the issue a success. So thank you, and I'm going to ask you to join me in thanking them and have the next panel come up and we'll get some. I'm going to go ahead and introduce our next panel, who really are a continuation of the discussion we just began, because this panel is looking at various dimensions of equity. We'll hear from Steve Wolf, who wrote sort of the overview paper for the issue describing the topic. He's the director of the Virginia Commonwealth University Center on Society and Health, and professor of family medicine and population health at VCU. Mariana Arcaya is an assistant professor of urban planning and public health in MIT's Department of Urban Studies and Planning. Julia Berenson is a research associate at the Center for Health Innovation at the New York Academy of Medicine and a PhD candidate in social policy analysis with a concentration in economics at the Columbia University School of Social Work. And Joaquim Hiro, a recent graduate of Harvard University's Health Policy Department, who is starting a postdoc at Harvard Medical School in the Department of Population Medicine just next month. So let me turn it over to Steve to kick us off.
Thank you, Alan. Good morning, everyone. Thank you for coming. I thought the journal was being generous to me when they gave me 4,500 words to summarize the issue of health equity, but now my challenge is 5 to 7 minutes to cover the topic, so bear with me here. I think that it's important for us to begin the discussion of health equity by reminding ourselves of what actually shapes health. Because if, as Dr. Braveman was pointing out, if we want to do something about closing the gaps that we're interested in, we need to think about those drivers. Let's start with the foundational principle, which is that health does vary dramatically in the United States. It varies by demographic characteristics, race, ethnicity, socioeconomic status. You can look at, and we don't have time to go through all the data, but there are large gaps in life expectancy at the national level, the state level, the county level. And in many of our cities, and our center's been involved with this, we've documented differences in life expectancy of 15 or 20 years between nearby neighborhoods that are separated by just a couple of miles or one exit on the interstate. So we have big differences in place and large differences in socioeconomic status. So that begs the question of why. Why is it that we have such big differences in health? And the answer is that we need to look at what causes health, what shapes our health. This simplified schematic, the more detailed one is impossible to read from the back of a room, sort of reminds us that if you think about health on the far right-hand side of the slide, we know that healthcare is important, and much of the content of the theme issue brings you evidence and research progress on how healthcare systems are trying to tackle the problem of health equity. But even if we had a perfect healthcare system and achieved perfect delivery of healthcare across these demographic groups, we would not eradicate health inequities, because healthcare only accounts for about 10 to 20% of health outcomes. Our health is shaped also by our health behaviors, how, whether we smoke, whether we're physically active, in our diet. But those behaviors, our ability to make healthy choices and frankly to access health care, depends very much on our environment, where we live. Do we live in a community that allows us to be physically active, where we have access to healthy foods, where we have safe and healthy housing and transportation services and so forth? And do we have a social environment that's good for health, where we don't have isolated communities, segregation, and so forth? Our ability to make healthy choices and frankly to live in those healthy environments is influenced by our socioeconomic status. So if we have limited education or limited income, we can't afford to live in the good neighborhoods that have those better health resources. And all of this, and that's the box that you see at the bottom, that all of this, by which I mean the healthcare system, the socioeconomic conditions, our environmental characteristics, are ultimately shaped by public policies. The choices that we make as a society here in Washington, at the state and local level, by business and other major sectors in our country, determine what those boxes look like and actually account for a lot of the health inequities. We also need to remember history. Policies and decisions made decades ago, such as redlining of neighborhoods back in the 1930s and 40s, created the segregated neighborhoods and areas of concentrated poverty that we now live with today. So if that's true, then it follows that the solutions to dealing with health equity involve policies in healthcare, but also outside the clinic, in other sectors that shape those conditions that we just talked about. So you see the list here, and we don't have a slide long enough to list all of them, but some of the major ones are listed there. Dr. Braveman mentioned education, employment, having a living wage, and so forth. Time is limited for me here, so I just want to make an important point, which is that healthcare is not the only sector that's concerned about equity. If you look at every one of these sectors, we could have an event here at the National Press Club around each of those bullets where people would be getting up and talking about inequities in access to a good education, inequities in getting a living wage, inequities in fair housing, social justice, criminal justice, and so forth. In each of these sectors, not just health, we have people working on the front lines in the trenches trying to deal with disadvantaged populations that are not getting the best outcomes. But all of them, including the health sector, look upstream and say, these Band-Aids aren't going to solve the problem unless we deal with the root causes. So that's what the tree is there. It's not a great graphic there, but what I'm trying to point out is if you think of our overall well-being as the canopy of the tree, and each of those branches is the different sectors that shape our well-being. We want to be healthy. We want our kids to have a good education. We want to live in a good neighborhood, and so forth. Housing, transportation, education, and so forth are each of the branches of that tree, but the root, the trunk of the tree is opportunity. All the policy sectors that we're talking about see the need for promoting opportunity by giving our young people better education and by providing opportunities for economic developments of families as well as communities. All of these sectors recognize that if we could make progress on those fundamental root issues, we would see the gaps in opportunity closing, and each of their sectors see improvements in meeting the needs of disadvantaged populations. So therefore, we see an opportunity here, sorry for using that word again, that there is a shared interest across sectors in trying to address those issues. And frankly, none of them can achieve transformational change in those sectors without cross-sector collaboration. So what's exciting about the future of dealing with inequities in health and in other domains is the energy that's developing in communities around the country in this type of cross-sector collaboration, because each group has recognized that they can't do it alone, and that dealing with one single domain rather than the multifactorial milieu that affects these outcomes is not able to achieve meaningful change. We now recognize these interdependencies. You can't address the public housing problem without providing early childhood education. You can't deal with the employment problem if there isn't transportation to get you to good jobs. Health also is one of those, and it depends very much on those intersections. As Dr. Betancourt said, the energy for moving forward in these cross-sector collaborations comes from recognizing where is the sweet spot that gives us aligned incentives, where each of those sectors gets something out of it, has something to gain by partnering with the other sector and coming up with a meaningful solution. Those discoveries are being made in communities around the country where various sectors are recognizing those opportunities. It allows them to leverage resources across sectors so that we're not duplicating the same efforts. And it creates an environment where we have a more compelling business case, a more compelling ROI for making these investments. The graphic on the right is an example where the center of the circle is showing you improvements in education. And if you think only with your health lens on and look down there at 7 o'clock, you would say, well, the ROI of investing in education is we're going to have improved health, and that means lower health care costs and therefore lower costs from Medicare and Medicaid. That's the payoff for improvements in education. But if you back away from the health lens and think across sectors, then you start seeing the payoffs around the dial of that watch. We improved education means a more productive workforce, reduced demand on social services, decreased costs for correctional facilities, more tax revenue coming into government, and so forth. Add those benefits into the ROI, and you have a more compelling business case. That's why employers, Fortune 500 companies, the financial sector are now coming out with reports on the social determinants of health because they're seeing the business case for making those investments. I want to close with just a mention of where we are today. The 2016 presidential campaign, I think, raised awareness about the broader scope of inequities that exist not only in health but socioeconomically. It certainly cast a spotlight on the plight of rural Americans. The epidemiologic literature, meanwhile, has been documenting in that same population a very alarming trend of rising mortality rates. Many of the red states and red counties that voted for President Trump are experiencing a dramatic increase in mortality rates, while mortality rates in other racial and ethnic groups have decreased. So we now recognize that the health inequities that concern us in inner city urban populations that often affect communities of color and concentrated poverty are also being experienced in a slightly different frame by other populations and other geographies. And that means that our policy solutions need to involve not only solutions in urban contexts, but also thinking about rural America and how we can promote opportunity in those settings. We are, what's that? Gotcha. Yeah, I got to wrap up here. We are at a period of uncertainty around what decisions will be made in Washington. And in particular, the concern is that policies may reduce investments in some of these very ingredients for social and economic opportunity. For that reason, there is a sense that more opportunity in making these transformative changes will come at the state and local level, particularly in communities where cutting-edge, transformational innovations have been launched to achieve collective impact in addressing these sectors. Thank you for your time.
Hi, I'm Mariana Arcaya, and like Dr. Wolf, my co-author on this commentary, Jose Figueroa, and I also took a wide-angle view of the factors that drive health disparities, but we look towards the future in thinking about what lies ahead as we try to pursue health equity in the coming decades. And the commentary I'm going to discuss today takes the position that there are powerful social trends in play that could threaten health equity unless we can mount a proactive response. We organize these challenges into 4 areas: healthcare technologies, health reform policies, widening socioeconomic inequality, and environmental threats. We discuss both hazards that put vulnerable groups at risks, as well as innovations that unevenly benefit privileged groups. We couldn't empirically study the future causes of health disparities, so we focused on trends that either affect health directly or those that change the distribution of power, risks, and resources in society. And we looked at trends that affect large numbers of people and those that we know are already underway. In terms of healthcare technology, we note that new technological progress against disease, whether in the form of drugs, diagnostics, or devices, can widen disparities between well-off and poor patients. Precision medicine, for example, is expected to deliver clinical breakthroughs, but these will likely disproportionately benefit privileged groups. We also note the differences in the ability of safety net versus well-resourced hospitals to adopt health IT, such as telehealth or wearable technologies to monitor patients, have serious distributional consequences for the poor and predominantly minority patients served by safety net hospitals. Second, we highlight current efforts to repeal and replace the Affordable Care Act without sufficient protections for the sickest and poorest Americans. 27% of non-elderly US adults have pre-existing conditions, and this group disproportionately includes racial and ethnic minorities. Leaving this group, those with pre-existing conditions, uninsurable or insurable only at extremely high personal costs, could widen racial and ethnic disparities in healthcare outcomes. Medicaid expansion under the ACA provided coverage for 11 million new enrollees and substantially reduced racial and ethnic disparities in coverage. Reversing Medicaid expansion would not only jeopardize access to care for the socially vulnerable, but could also threaten gains made in narrowing these disparities. Because Medicaid buffers low-income people against financial risks, loss of Medicaid coverage would also likely exacerbate the already wide disparities in financial security between lower and higher socioeconomic status individuals. In the third section, we discuss changes in the way that wealth is generated and to whom it accrues. We note that these changes are disproportionately benefiting those who are well off while leaving more vulnerable groups behind. Why? In part, the US economy is becoming increasingly financialized. Even non-financial firms now generate a growing share of their earnings through investments, not production, which means that corporations can turn profits without always having to hire full-time workers. And at the same time, we're seeing increasing wage premiums associated with working in management and finance, jobs that we note are disproportionately held by white men. We also discuss the implications of computing innovations, including machine learning and artificial intelligence for the future of work. In short, workers in routine, low-wage jobs that require less education are predicted to experience rapid, disruptive changes in the type of work that's available to them, while those with higher skill levels are making greater strides than ever before. Next, we discuss growing environmental hazards. The past 50 years have seen exponential growth in the number of chemical compounds that are isolated or synthesized by industry. But we don't have a good handle on the health implications, particularly the life course, cumulative, and interactive effects associated with exposure to most of these compounds. We note that public discourse around this problem increasingly focuses on precautionary consumption, the attempt to protect yourself against ubiquitous environmental threats by changing your consumer behavior. Think about organic foods or all-natural baby products, for example, while regulation and stringent testing are less emphasized. A precautionary consumption approach to protecting citizens against emerging environmental threats is an insufficient strategy, but any effectiveness that it has will only benefit those with the education, money, and bandwidth to identify and purchase these potentially safer but often more expensive products. Finally, we discuss climate change, which is on track to kill 250,000 people annually by 2030, according to conservative estimates. Climate change, which causes more frequent and intense storms, flooding, fires, heat waves, drought, introduces serious population health risk factors, such as growth and disease vectors, food insecurity, violence, political conflict, mass displacement, and more. The people least responsible for this problem, the poorest and most socially vulnerable, already bear the brunt of climate change impacts and are expected to do so going forward. So what can we do? Our commentary suggests specific measures in each of these domains. For example, ensuring that the ACA is not replaced and repealed without a plan for providing affordable access to health insurance for poor people and people with chronic or pre-existing conditions. We also identify efficient cross-cutting solutions, and you heard Dr. Wolf and Dr. Betancourt refer to these as win-wins. For example, investing in renewable energy and other green tech initiatives, which can create jobs and address environmental threats. We point to evidence that some investments are known to support social mobility, education, transit, healthcare, environmental protection, and that these investments should help address multiple problems at once by reducing social inequality overall. And finally, we suggest that a multi-sector policy advocacy coalition come together around a new health equity agenda, which we think should include the following: sustained attention to the underlying inequalities in social, economic, and environmental exposures that drive health disparities. Research and innovation in partnership with marginalized communities to ensure that vulnerable groups aren't left behind as technology and clinical care progresses. Stronger regulation of industries, be they in sectors that release environmental toxicants or those that introduce toxic financial products to protect ordinary citizens. Increase political power and investments in social mobility for marginalized populations in order to lower overall levels of social inequality. And more research on how social and environmental exposures interact to reproduce or stem health inequalities. In short, we see the world is changing, and while it's changing for the better in many ways, for example, as clinical care progresses, working towards health equity means grappling with the inequitable distributions of the risks and benefits that are associated with technological progress, grappling with historic levels of wealth and power inequalities, and with the fact that there are currently insufficient medical, financial, social, and environmental protections that everyone needs in order to be healthy.
Hello, my name is Julia Berenson. I work as a research associate at the New York Academy of Medicine, which is an interdisciplinary research and policy center dedicated to advancing the health of people living in cities. And today I'll be discussing findings from a paper in which my colleagues and I examined state policy action to create healthier and more equitable communities. As Stephen described, across the US, health gaps persist. This graph shows a health divide in age-adjusted death rates by state. We can see there's a high in Mississippi to a low in Hawaii. Existing literature has also identified determinants of the aforementioned health gaps. In addition to clinical factors and health behaviors, the social determinants of health affect population health and health equity. There also is growing evidence of policies that address the determinants of health that can reduce health inequities, including early education and income supports. Widespread awareness of that evidence underscores the need for action. State governments can make changes to economic, educational, environmental, and healthcare policies that impact population health and health equity. In fact, my co-authors and I started working on this research upon reading a study that links state budget cuts in maternal health care spending with worse maternal mortality. We became curious about what policies are state governments actually enacting or not that can promote or deter health equity. And it became clear that state governments are in need of evidence and guidance about which of their existing policies can address health inequities and approaches for them to take action. Sir Michael Marmot, who many of you might know, who's a leading scholar on health equity, introduced a simple mnemonic for how state governments can take action on social determinants to improve health equity. Do something, do more, and do better. And this became the mantra for our study. States performing poorly can begin by doing something. States with mid-performance can do better. And states with high performance can aim to do even better. So to find out what's working around the country and what approaches state governments can take to do more and do better, we developed a scorecard on state policies to address the 5 domains that impact health equity. This figure here shows the model of population health, which we use as a conceptual framework for our scorecard. The model has 5 modifiable, measurable domains that are determinants of health, which our previous speakers went over: health behaviors, clinical care, social factors, economic factors, and the physical environment. Our scorecard measures indicators related to the use of evidence-based policies to address each of the 5 domains related to health equity. Here is a list of the scorecard measures. Note that the measures capture policies for which there exists strong evidence of their impact on population health and health equity. State governments can enact these policies, and data are publicly available, tracked at the state level, and are recently and regularly updated. Note that for each of these domains, multiple indicators could have been used. Ultimately, we select 1 indicator per domain. While additional measures exist, this scorecard is a first start at a dialogue about what evidence-based policies states can feasibly enact to achieve health equity. The following slides provide some examples of how we measured and ranked 50 states in the District of Columbia based on their performance in enacting specific evidence-based policies in the 5 domains. For example, we used the cigarette excise tax as an example of a state-level policy that can close the health equity gap by enacting on health behaviors. Note that 7 states in the District of Columbia have, just turned too far. As you can see, there's a range of performance. We categorize states into low performance, mid-performance, and high-level performance. The tax on cigarettes range from a low in Missouri of 17 cents, which notably has not raised its rate since 1993, to $4.35 in New York, where I live. 8 states excel with having a cigarette excise tax at $3 and above. Next, our scorecard uses the Medicaid expansion and coverage gap as a state-level policy that can address health disparities by improving access to clinical care. Notably, 31 states in the District of Columbia lead with adopting the Affordable Care Act's Medicaid expansion. On the other hand, 19 states have decided not to expand Medicaid eligibility. For the domain of economic factors influencing population health, our scorecard measures legislated state minimum wage as of 2017. And like the cigarette excise tax, we divide states into 3 categories of performance. And notably, only 7 states in the District of Columbia have minimum wage levels above $10. And the District of Columbia, where we are today, leads with a minimum wage of $11.50. So overall, our scorecard reveals that states vary substantially in enacting each of the 5 evidence-based policies. Few states excel in enacting all 5 policies. Several states lead in one domain but lag in performance in others. For example, some states that had a low cigarette excise tax earned high scores for state-funded pre-K, such as Georgia. Many states are underperforming in key areas. 21 states have minimum wage levels that are at or below the federal minimum. and only 5 states have enacted policies that increase access to early childhood education, having 50% or more of 4-year-olds enrolled in state-funded pre-K. And there was no overall clear regional trend of performance. Notably, several southern states had a high share of children enrolled in state-funded pre-K, but on the other hand, many of these states have not expanded Medicaid coverage, and many uninsured adults experience coverage gaps. Now, there are promising examples of states that are taking action to achieve health equity. Recent policy changes demonstrate that it is possible for governments of poorly performing states to begin by doing something. In addition, states that are already doing some of the things on our scorecard can strive to do more, and leading states can find ways to do better. For example, Louisiana, despite being in the deep south among all the other states down there that have not yet decided to expand Medicaid, Louisiana has gone against the grain and expanded Medicaid most recently. In addition, California in 2016, voters passed legislation to more than double the excise tax. And this is for the first time in 18 years that has been done. Doing more, Arizona raised its minimum wage recently to a level that now sets Arizona in high performance. And lastly, several states are doing better. Among states that have expanded Medicaid, several, including Massachusetts, New York, and Vermont, have been awarded funding to test new models of care. Finally, just to conclude things, states can make policy changes that create healthier and more equitable communities. Our scorecard provides a useful tool for state governments to achieve this. We identify feasible, effective, evidence-based policies and approaches for states to take. Note that we only studied some of the policies, that this is a first effort, and future more comprehensive scorecards can be designed based on the process outlined here. And rankings do not definitively indicate overall performance. States may be doing things that we have not highlighted in our scorecard, but again, we aim to expand the list of measures in future efforts. And finally, the scorecard aims to start a national dialogue about what states can feasibly do to create healthier and more equitable communities. Thank you.
Thank you. Good morning, everyone. So it's abundantly clear that large health and healthcare disparities exist in the United States, but how large is large? And how do populations feel about disparities, particularly in the United States relative to other countries? To consider these questions, we used population surveys in 32 different countries across the world to place health and healthcare disparities in the United States, as well as awareness of and views of inequality in a broad international context. And
a couple forward.
Oh, yeah. And I'm Joachim. We used the International Social Survey Program, which is a consortium of academics and polling experts who put out yearly modules that use identically worded and ordered surveys to answer important questions that are of interest to social scientists, and for the express purpose of making international comparisons. The health module was done in 2011 and fielded in the United States in 2012, so before many of the reforms of the Affordable Care Act, and so the results here are not going to reflect any changes that have happened since then. These surveys tend to be quite high quality with good sample sizes and response rates that often exceeded 50%. In the US, it was fielded as a part of the General Social Survey, which has response rates over 70%. We selected outcomes from this survey in both health and health care, including self-rated health, whether or not people had not gotten care that they needed because of costs, people's satisfaction with their recent medical care, as well as how confident people were in being able to get their preferred care in a time of need in the future. And we were also able to compare countries in their public views, the perception of the degree of unmet need among populations in the countries, as well as their perceptions of the fairness of income-based healthcare disparities. How we measure disparity was pretty straightforward. We took the difference in the rate of negative health or negative health care experiences among people in the upper third of household income compared to people in the bottom third of household income, and then we ranked countries based upon the size of that disparity across each of the measures. And because how disparity is measured is sensitive to how it's parameterized, we conducted a number of robustness checks, and while it did make a difference for some countries in the United States, it didn't really change how we compared to the other countries in our sample. So what we found was that across practically every measure, the United States compared unfavorably to the other countries in our sample. People who placed in the upper third of income generally were more positive about the care that they received, experienced lower barriers to receiving that care, and were more confident about getting their preferences. What I show here, I highlight 3 of the health care measures, showing the top 10 most inequitable countries and the bottom 10 most equitable, or the 10 most equitable countries, omitting the middle countries for space concerns, and also highlighting the United States in blue, both adjusting for insurance status and not adjusting for insurance status. And what this shows is that while insurance status does make a difference in how wide healthcare disparities are in the US, they don't tell the whole story, and even after adjusting for insurance, the U.S. still was among the most inequitable countries across all the measures that we looked at. So we also compared how people's perception of the degree of unmet need in their country, and how they felt about the fairness of higher income people being able to afford better care than lower income people. And so at 67%, a very broad segment of the US population is aware of the problem of unmet need. This was well above the proportion in any other country, exceeding 10 points the next highest country in the sample, which is Poland. And in spite of this context, in spite of this broad awareness, the United States placed in the bottom third of countries in the portion of the public who felt that it was unfair that people with high incomes could afford better care than people with lower incomes. So this sort of raises this question of whether or not there may be a kind of greater tolerance among the American populace for healthcare inequalities. So it can be difficult because of the complexity of healthcare systems and the interconnectedness of particular features of any system to try to pinpoint precisely what features of a system might be more or less associated with certain types of healthcare disparities, although it certainly can be done, although that wasn't a focus of our paper. Although it was readily apparent from the data that the countries that tended to top the list in healthcare disparities were those where healthcare access was not universal. They also tended to be countries that were middle income, with the United States being the exception. Again, this is not just a matter of insurance status in the US, and it makes the point that if we want to achieve broader healthcare equity in the US, we're going to have to look beyond just providing coverage for the entire population, but also looking at the disparities that arise among the insured population as well. But I'd also like to note that insurance does matter. And so on the flip side of that, if if we want to improve our relative standing to other countries, any change to the healthcare system that would undo any gains that have happened in the number of insured since the ACA would not be the way to go. And I'll just wrap up by saying that it's clear, I think everyone knows that the political environment for addressing this issue is challenging. And with less prevalent concern for income-based disparities in the US relative to other countries, amid this context of a broad awareness that significant unmet need exists, signals that maybe part of that challenge may also be one of political will. And in addition to this, a recent poll by one of my co-authors also found that beliefs about how we can address this issue, notably the role of government, is very sharply divided along partisan lines. And so in order to make headway in this area, I think that it will involve both figuring out how to make the case for broader health equity, making it compelling to the public, but also doing it in a way that avoids dividing lines in politics. So I'll wrap up there. Thank you.
I want to ask a few questions of one question of each of you, just to clarify some points and expand on some. Steve, let me just start with you. You noted accurately, of course, that there's an equity discussion going on in other areas than health. Like many other things, health being a sixth of the economy, we sort of forget that there's another world out there that isn't health. And I wonder if you could talk a little bit about what health could learn from those discussions in the other sectors. I'm thinking particularly of an area like education, which, like healthcare, on the one hand, there's inside, as Joe was talking about this morning, sort of inside the system, what do you do to address equities? But of course, so much of inequity in education is also tied to broader social context. And so I'm just wondering if, as you've thought about equity in healthcare and thought about the discussions going on in other sectors, whether there's anything you would want to bring into the healthcare discussion that you've seen going on elsewhere.
Well, I think you rightly point out the parallels. I think in many of those same sectors, there are efforts being made within the sector to do the best you can in the classroom for disadvantaged students, or to provide better housing, address public housing problems. But I repeat what I said in my talk, that I think there's a general recognition in each of these domains of our interdependencies, and a frustration in many of those sectors that they cannot fully solve the problem without partnerships with other sectors, without the other ends being met. And in many ways, they are at a disadvantage relative to the healthcare industry, which has a lot of capital flowing through it. And in those other sectors, they're operating on much more stringent budgets, and their resources are much more vulnerable.
Mariana, you, to a listener, it was a pretty bleak picture of some of the effects of these changes on equity. And then the agenda to address it was very expansive. I wonder if, to calm me and maybe others down a bit, you could reflect on whether the 4 areas that you saw, whether, as you were thinking about this, you feel that the pace of change in those 4 areas is faster or slower than it was in the past. In other words, if we'd asked you to write this paper 20 years ago, you probably also would have been able to find lots of signals that things were going to get worse, but one of your areas was coverage, where we've actually made some progress. So can you just give us a little context to understand rate of change in addition to just the 4 areas of vulnerability?
Yeah, sure. And sorry for being bleak. We tried to make and maybe it came across better in the commentary than in the talk, that things in many ways are getting better. But if things are getting better at a faster rate for well-off individuals and groups, everyone can be sort of improving their status, but the gaps can still be widening. And so, the idea isn't to be bleak on all fronts, but just to say, as we see positive change, let's make sure that those positive changes are accruing to vulnerable groups, marginalized groups, excluded groups, in addition to the well-off groups. I think about the pace of change is a really interesting question. There have been cases made that we're very focused on how technology is transforming our world, but if we thought about the difference between, the annual difference now, or the 5-year differences now versus the 5-year differences as associated with, having electricity within homes, or having even just the advent of the internet, are these changes really all that different? I think that though that what the concern is that we have multiple factors happening at once that are basically reinforcing inequality, so that the haves get more and the haves not get left behind. And so a lot of the trends that we're seeing, especially around technological progress, right? They're sort of, on one hand, making it such that people who have capital, who have power, who have skills, are doing better than ever before, are able to capture a lot of the gains associated with the productivity increases of technology. And those who are starting out with sort of fewer resources, less power, and fewer skills are sort of being left behind in this race. And so, again, sorry to be bleak about it, and I think there's a lot of room for optimism. And the coverage example you gave is a good one.
Thank you. Julia, part of the earlier discussion was about, in pursuing equity, to look at terms like return on investment and win-win and the like. I realize you didn't do an in-depth study of all of these states and what the debates were when they adopted the policies. Mm-hmm. But as you think about the policies you selected and where you see states lining up, do you have a sense of whether improving equity was an underlying goal of these, or it's sort of a byproduct? Was there a sense of these are win-win return on investment policies, or is it really almost happenstance that you see alignment between these and the equity agenda?
Well, I think actually a nice example is what took place in Louisiana, as I briefly mentioned in my presentation. So Louisiana was the last state to expand Medicaid. And again, the only state in the Deep South to do so. The governor was having what I would call some trials and tribulations with the fact that lawmakers were concerned about state budget. And they justified expanding Medicaid because of not only the value it would bring to low-income populations, but also found an innovative way of expanding Medicaid by piggybacking on existing programs for low-income populations in that state. So I think it was a nice example of the state recognizing how a policy can impact health, that there's evidence behind it, but also recognizing that there are state budgetary concerns and finding an innovative way of implementing the policy to meet the needs of that state's concerns.
Thank you. Joachim, you focus on disparities, which is, of course, the topic. It's hard to talk about disparities without talking about level, because as Mariana just described, you can have improvement, and it can either affect everyone or not. When you look across the countries, again, this is broad brush, but I'm trying to get your sense of whether, is there a correlation between people's views or attitudes or experiences in disparity with level, or are these just two totally separate phenomena?
So you're saying, is there a correlation between sort of attitudes towards the disparity with the level of disparity?
So, I mean, you looked at different dimensions. Attitude would be one, even just the access experience. But on any of these measures, it seems like looking at disparity without having some sense of level, you sort of have to look at the two together. So I'm just asking you to add the other.
Yeah, well, I mean, part of it depends on kind of how you're measuring disparity. So if you're concerned with really the relative positions of people in the advantaged group versus the disadvantaged group, then taking the ratio between those two is going to exaggerate the amount of disparity that you observe among countries that are doing quite well in terms of level. And that's actually part of the reason why we chose to show our results in terms of simple differences, because in some ways it kind of handicaps the countries that are doing quite well on level. You're able to see that in the paper when we compare countries based on self-rated health, and that levels of self-rated health are in fact, or tend to be better in countries that are wealthier than in countries, the middle income countries that we included. But in my view, the size of disparity that exists in countries, particularly in the United States, is large enough that mean improvement or mean improvement in level it really isn't enough to justify the amount of disparity that exists between those groups.
Thank you. We're running a little behind, but I do want to get one or maybe at the most 2 questions in. But let's go ahead. Wait for a microphone. Please identify yourself, and we'll do these as quickly as we can.
Hi, thanks. Am I allowed to ask something of the first panel as well, or no?
I think we need to kind of
okay,
keep it.
I'll focus.
Okay.
No, this is fine too. But it was just could be anybody could answer it. I'm Jane O'Donnell with USA Today, and I co-founded the Urban Health Media Project, where we're training high school students in DC and Baltimore to do health and social issue journalism, everything you're talking about today. Education is, of course, of great interest to them. They're in the middle of it. But mental health is the thing that almost all of them want to write about, and because it affects them very directly and in their families. There seem to be some cultural issues around, it's not only access to mental health, it's cultural issues around stigma and things like that. I wondered if any of you would touch on that and how you think it might, and particularly, I think it's Joseph, just, whether that's come up in any of your, I'm sorry, Stephen.
I'll jump in there. I think it's a hugely important issue. It always has been, right? I mean, for generations, we've been concerned about the lack of equity in terms of dealing with mental health issues. But now we're seeing it punctuated. I mentioned the rising mortality rates that we're seeing lately. Those are being caused by drug overdoses, and that the opioid epidemic has received a lot of attention. But other stress-related conditions are responsible for that rise in mortality rates. Our research and others has shown spikes in suicides, alcohol, problem drinking, and a variety of other issues that we potentially would link back to depression and anxiety. It makes sense that people living under disadvantaged conditions who are victims of the inequality that Joe was talking about would, over time, especially if they have a sense of hopelessness, experience greater psychological morbidity. And now we're seeing the consequences in terms of them turning to drugs, to alcohol, and ultimately, in the more tragic cases, suicide.
So, I think just to key, we've got so many papers in this issue. I'm going to thank our panelists for a terrific job, ask our next to come up. Please join me in thanking. So I'm going to keep us moving so that we can take a brief break. Yes, someone had a pen here. We'll make this as seamless as possible, and you all will get a break after this panel. But we had a discussion of the elements of health equity, and now a panel focusing really on interventions and approaches that are designed to address some of these social determinants of health. If you all would join us up here. Okay, I'm going to go ahead and begin with the introductions. Shira Shavit is Associate Clinical Professor of Family and Community Medicine at the University of California, San Francisco. Andrew Fenelon is Assistant Professor in the Department of Health Services Administration in the School of Public Health at the University of Maryland, College Park, and a Faculty Associate at the Maryland Population Research Center. Scott Cook, Clinical Psychologist, with work serving urban and rural populations affiliated with the University of Chicago School of Medicine. Robert Drake, Andrew Thomas Professor of Health Policy and Clinical Practice at the Geisel School of Medicine at Dartmouth and Vice President at Westat Corporation. I will turn it over first to Shira.
Good morning, everyone. Oh, wow. I think we need a coffee break. We'll try that again. Good morning, everyone.
Good morning.
Great. I'm Shira Shavid. I'm Associate Clinical Professor of Family and Community Medicine at UCSF. I'd like to acknowledge my co-authors on this paper, my colleagues at Yale and City College of San Francisco. I'd also like to thank Health Affairs for giving us this wonderful opportunity to share our findings with you. I also would like to acknowledge that this study was in part funded by CMMI. Our program officer, Debbie Rogel, is here today. I want to thank her. But I do need to let you all know that the findings shown here are really our findings, and we are not in any way representing the U.S. Department of Health and Human Services. So I'm going to just jump right in the interest of time and talk a little bit about the setting for our work. So low-income and minority individuals are disproportionately impacted by criminal justice policies in our country, which further worsens health disparities. The Transitions Clinic Network is a network of primary care clinics that are mostly federally qualified health centers that are aimed at improving the health of individuals with chronic medical conditions returning home from incarceration. Individuals who are in prison have higher rates of some chronic medical conditions, substance use disorders, and mental illness. And upon release from prison, these individuals experience high rates of emergency room utilization, hospitalizations, and an increased risk of death. People coming home from prison experience they're 12 times more likely to die in the first 2 weeks coming home as compared to their peers in the community. So the Transitions Clinic Network is really aimed at trying to address those disparities and close some of those gaps for individuals with chronic medical conditions returning home from incarceration. Because of sort of the feeling of real imminence of trying to help people and first coming home with this high risk of death, the Transitions Clinic Network aims to get individuals into care within the first month upon return from incarceration, so this early engagement piece, and also works to broaden their scope of referrals, not just from community providers, but to correctional systems, in the thinking that by connecting with people early in the process, they might be able to address some of these issues and really move the needle on some of these disparities. Some of the other unique characteristics of the Transitions Clinic Network model is that each site hires individuals who have been impacted by the criminal justice system as community health workers, and these individuals help patients navigate not just the complex system of healthcare, but also the social determinants of health that many people face upon return home from the community. So these programs are looking to expand addressing not just disparities in healthcare, but disparities across social determinants of health that individuals face in coming home from incarceration. So these data that I'm going to present today come from the CMMI award that the Transitions Clinic Network received in conjunction with our partners at City College of San Francisco. So this award was provided in 2012 with the goal to provide care to 2,000 individuals with chronic medical conditions returning home from incarceration in 13 programs in 6 states in Puerto Rico. So most states expanded, one state did not, and then the other state was ineligible for expansion, which is Puerto Rico. So previously, the Transitions Clinic Network had been evaluated with a randomized control trial, and what was found that individuals that participated in the program were less likely to use the emergency department and had a 50% decrease or 50% fewer emergency room visits. So in this particular study, what we aimed to do was to get a better sense of how specific characteristics of the Transitions Clinic Network, particularly early engagement into care and referrals from correctional partners, impact acute care utilization, such as emergency room visits and hospitalizations, as well as how it impacted recidivism. So our study design was a prospective cohort study. At baseline, all comers to the Transitions Clinic program were enrolled in the program, so anybody with any chronic medical condition who had been released from prison in the last 6 months We surveyed these individuals as well as collected information from their health records as well as criminal justice records. Our predictors of interest were both time to engagement and referral source. So looking at engagement in the first month post-release versus individuals who engaged in 1 to 6 months post-release. And then for referral source, referral to TCN primary care from correctional partners versus the usual referrals from community partners. Our primary outcomes were acute care utilization and recidivism. And for recidivism, this was any return to jail or prison in 12 months following release. So what we found was that these individuals who were our TCN participants were poor people of color who had a high burden of both social determinants of health needs as well as a high burden of health needs. 85% of these individuals had at least one chronic medical condition, and 46% reported their self-reported their health as fair to poor. So when we looked at time to engagement, 53% of TCN participants engaged in care in less than 1 month post-release, and for referral source, 30% of the referrals came from our correctional partners. So I don't actually have time, looking at the time, I don't have a lot of time to go into this, so I'm going to summarize these slides, but these are all in the paper, and this looks specifically, these are our results, and really what we're finding was this. For the individuals who, in the 12 months following release, were referred to correctional partners, they had fewer acute care visits as compared to those referred by community partners. But for those that were engaged in TCN in less than 1 month following release, that was actually associated with more acute care visits. And then neither time to engagement in TCN primary care or the referral source was significantly associated with recidivism. So I think one of the things I just want to point out in the few seconds I have remaining is that, this does have significant policy implications, in particular with our most positive findings, which was that referrals by correctional partners did reduce acute care visits for our patients in the TCN network. And I think this is really important to think about. This association makes sense to then invest in better linkages between the correctional health systems and community systems if we really want to address some of these broader issues of health equity in this patient population. And some of those investments could be things like investing in more medical records, electronic health records between systems, having discharge planners at prison systems, connecting individuals from prison to the community, allowing community health workers from the community to come into prison systems or other health systems to in-reach into systems to really build this continuity of care between the prison and the community. So with that, I want to thank you all and I look forward to the discussion in a few minutes.
Hi, thank you. I'm Andy Fenelon, and I want to acknowledge my co-authors, especially Alan Simon, who wasn't able to present today. But I also want to specify that any statements I make here are my opinion, not those of the agencies for which my co-authors work. I want to do my best not to get them in trouble. So the way I think we're coming at this is from the idea that social and economic policies created health disparities that we see today. And so in order to address those disparities, we're going to need social and economic policies. And one that we're focusing on is HUD housing assistance. So we also find ourselves in a pretty serious housing affordability crisis. Increasingly low-income families are spending more than 30% of their income on housing, and at the lowest levels of income, you're seeing the majority of families spending the majority of their income on housing. And so I sort of think of this as maybe one of the most pressing socioeconomic issues of our time, not just because it has implications for the stability of housing, but also for income to spend on other things like health-promoting investments. And so this is sort of an increasingly important role for HUD's housing assistance programs, which improves both the affordability of housing, but also stability for low-income families. And the increased income that comes from getting access to housing assistance can be put to other uses. In our case, we're looking at increasing access to affordable health care. So we already know from some recent evidence by some author, I don't know that name, that housing assistance has been shown to lead to improvements in adult health and well-being. And so it's not inconceivable that we would also see improvements in access to care. So in order to look at this question, we're using a really unique data set. It's a linkage of the National Health Interview Survey to HUD's administrative records. And this is really unique because the NHIS they interview around 100,000 people a year, and then once we link these individuals to HUD's records, we can have assisted housing histories for a lot of people. And so it's sort of the first opportunity to answer questions related to the impact of broad nationwide housing assistance programs on health outcomes, healthcare access. So we're looking at three measures of healthcare access. And they're actually, they could be better described as lack of access measures. So we're looking at whether or not someone has no insurance coverage, whether they have no usual source of care, and whether they've delayed or foregone needed medical care due to cost in the past year. So one of the challenges, I think, to studying a program like housing assistance is that it's not randomly distributed in the population, right? The person who gets access to housing assistance is going to be different from those who don't in a lot of important ways that are related to health and healthcare. And so when we're using cross-sectional data like NHIS, we have to develop some sort of method to get beyond this selection bias issue. So what we've decided to do is exploit this HUD housing history that the linkage gets us. And so we're exploiting the timing of housing assistance relative to when individuals are interviewed. So we're comparing two groups with respect to their HUD housing assistance participation. Those who are currently receiving assistance at the time they're interviewed. So the interviewer comes and they're currently receiving HUD housing assistance, and we know that from the linkage. And then a second group, which we call future assistants, those who are not in HUD housing assistance at interview, but we know that they're entering within the next 2 years, which is a good proxy for the HUD waitlist period. And so the idea is that these two groups are relatively similar in terms of a lot of background characteristics, but they differ in terms of whether or not they're receiving housing assistance. And so our basic results is that we find that receiving housing assistance leads to increased insurance coverage. And although we see it across many different types of insurance, this is largely increases in public insurance coverage. So for those in housing assistance, more likely to have health insurance. We also find that for those in housing assistance, they're less likely to have delayed or foregone needed medical care in the past year due to cost. So there's also improvements in the affordability of health care. And so just some important conclusions. And I think we would do well not to overlook the importance of this finding, that housing assistance actually improves access to health insurance and improves the affordability of needed health care. But another important finding is that we don't actually find differences by program type. And this has implications for HUD policy, since HUD is increasingly focused on housing choice vouchers as an alternative to public housing, but we actually don't find differences. We find similar improvements in insurance coverage and affordability for both these programs. We also find, but I didn't show the results, that the reduction in unmet healthcare need due to cost is not just due to people getting access to insurance. There's also this idea that increased flexible income as a result of receiving housing assistance is actually being put to good use. And so this is also something that's important not to overlook, is that when people are given more money, essentially, in terms of housing assistance, it's actually going to improving affordability of health insurance. And one conclusion that I didn't put on here, so as, again, not to get my colleagues at HHS and HUD in trouble, but to the extent that some of the new budgets that have come out in the past month or so go into effect, we're looking at reductions in investment in housing assistance, something like a 15% reduction just in 1 year. And so in considering the effects of these policies, we have to remember that it's not just threatening the stability and affordability of housing, but also the stability and affordability of access to health care. So thank you.
Hello, everybody. My name is Scott Cook, and I'm the Deputy Director of a national program of the Robert Wood Johnson Foundation called Finding Answers, Solving Disparities Through Payment and Delivery System Reform. I would like to acknowledge the co-authors on this paper, and it's a large group, so I couldn't get them all on the screen, but you can see it, of course, in the issue. So in order to talk about the results of this work that we did, I need to give you some history of our program, because it sets up the paper that we wrote. We were funded by the Robert Wood Johnson Foundation about 11, 12 years ago, at a time when we had a lot of data showing us that health disparities exist. It's a huge problem. Increased death, increased pain and suffering, increased cost for our citizens. And so we had all this data showing that these problems exist, but we didn't have a good sense of what to do about it. And so we worked with different organizations around the country, 33 healthcare organizations initially through a grants program, and also it included healthcare organizations as well as payers. In doing that work, we found organizations that had found disparities in their patient population, healthcare and health outcome disparities. They each had an idea about how to improve that situation, an intervention to reduce or eliminate that disparity. And we provided funding for them to do a good, solid empirical evaluation, quantitative and qualitative, on their intervention to see if it worked or did it not work. Also, how they went about doing it, the process of implementation. In addition to our own organizations around the country, and we had 33 healthcare organizations, but they all often had multiple sites. So we actually were working with hundreds of healthcare sites around the country. We also looked at what other people were doing. We conducted 11 systematic reviews of the literature around different health conditions to see what others were doing to try to address this problem. Again, looking at what worked and what didn't work, and also like sort of middling ground of people who had sort of some successes and some failures in their efforts. We came up with all of this information, all of this data, and put together what we called a roadmap to reduce disparities. So as you can imagine, there's no single magic bullet that healthcare organizations can implement to address these problems. Different healthcare disparities, or even the same healthcare disparity, can come about for different reasons in different locations, very specific to communities, specific patient populations, and therefore the ways to eliminate or reduce them are very specific to the healthcare organization in question. Their own resources, their own quality improvement infrastructure, and their own staff expertise. So no magic bullet, no easy out-of-the-box answer that other healthcare organizations can use. So we have a roadmap with guidance showing here are the commonalities of organizations that succeeded in this effort. Here are the commonalities of organizations that struggled. Here are steps you can follow in your own setting with your own staff, your own patients, your own payer mix to see what can work. So we took that on the road. We provided technical assistance to a whole other set of healthcare organizations to implement the roadmap. I'm going to pause right there because I sort of missed an important point. That important point being, we now know how to address healthcare disparities for the most part in our healthcare delivery system. That's incredibly exciting, right? That means less suffering, less pain, less death for our patients, less cost overall. So that's really key. We have a good sense about how to do this. As we took the roadmap on the road and we provided this technical assistance and worked with organizations, we found that even though organizations may have it in their mission and in their heart to do this work, it's very much part of their desires, they really struggle to get it done because there's no easy out-of-the-box answer. This takes time and it takes resources. All of our healthcare organizations are under stress right now. It's a rapidly changing healthcare system. There are multiple regulatory and accreditation pressures often changing on them that they have to pay attention to. It's a financially slim margin for them to succeed and survive, especially for our safety net settings. And again, just this rapid pace of change. So even though they want to do this work, even though we now know how to do this kind of work, they still struggle. We need a better business case. We need a better business model to give them the resources and the incentive and the time that they need to do the work. So we decided to take an additional attack, and we looked at the payment side of the system. We wanted to integrate how are we paying for care with how we deliver care, and are there ways to incorporate equity and disparities in how we pay healthcare organizations to do this work, so that they then have the time and the resources to make it happen. We're at a fast pace of change now in terms of how we pay for care, and that's an incredible opportunity. It's an opportunity that unfortunately we're missing in terms of equity. So as organizations move from being paid for providing high quantities of care, a fee-based system, fee-for-service-based system, a volume-based system, we're now encouraging organizations through a lot of different experiments in how we pay for them to improve quality and also reduce costs. So we're asking them to do a value-based approach to the healthcare that they deliver, and we're incentivizing that through how we pay for them. Lots of experiments going on in how we do that. Can't talk about that due to lack of time. But we have the opportunity now, if we're going to be experimenting with how we pay for healthcare organizations, we should be experimenting with incorporating equity and disparities focus into that pay in terms of how they are reimbursed for that care. So we need to be very intentional about that. We put out a call for proposals nationally to try to do this work. We asked each proposal applicant to have a marriage or a connection between two partners, a payer partner and a healthcare organization delivery system or single organization. And we asked the payer partner to design a new way of paying for care, a new value-based way of paying for care. And then that would incentivize the healthcare organization to change how they deliver care to address particular disparities in their patient population. To give you a sense of one of the findings that we talked about in this paper, when we put out calls for proposals in the past, those 33 healthcare organizations I talked about before, they were just talking about delivering changes to the healthcare delivery side. We received, for example, 177 proposals. So our healthcare organizations have a good sense of how to try to make this happen. When we put out this call for proposals in this new program with the marriage on the payment side and the healthcare delivery side, we only got 40 responses. And that's because it's a much higher bar. We don't know how to do this yet. We're still struggling to try to figure out how to make it happen. So we were thrilled to get 40 proposals, but it was still a significant decrease from what we'd usually seen before. And it's a national call for proposals, so we think about it as a proxy for where we are as a country right now in terms of trying to do this work. And it tells us that it's still something we're trying to figure out and we're still struggling with on how to make this happen. The other thing that we saw that was striking that isn't on the slide is that when we looked at the proposals and the payment models that were set up, none of them actually incentivized or required on the organization healthcare delivery side an actual reduction in the disparities they were trying to address. And that's the whole goal, right? So we were surprised to see that none of our applicants proposed that. And that's because it's a thing I think that makes organizations nervous. I think Joe mentioned that a little bit earlier in the first panel, that it's something we're all a little bit skittish about. It's something that we're not sure quite how to do in terms of this payment and reducing disparities impact. So with very little time left, I can't go into the details, but the exciting news is we have 3 proposals that rose to the top that looked at this marriage, and we've been working with them for a couple of marriage of payment and healthcare delivery. We've been working with them for several years now. We're collecting a good set of, again, quantitative and qualitative data in terms of the work that they're doing. The first names you see, George Mason, Icahn School of Medicine, University of Washington, those are academic partners. You will also see a payer partner in each of those grantees, Fairfax County, Virginia, partnering with first Molina Healthcare and then Innova. So they had a change in their healthcare contract with a healthcare delivery system. So that's why you see 2 healthcare delivery partners there. They're working in safety net clinics, 3 safety net clinics in Fairfax County, Virginia that have patients without insurance and who are not eligible for insurance. So very clear systems or communities in distress. looking at hypertension, cardiovascular disease disparities, as well as disparities in cervical cancer screening. Icahn School of Medicine, with Mount Sinai as the delivery system and Health First as the payer partner, a Medicaid managed care model. Looking at high-risk pregnant women on Medicaid, disparities compared to commercially insured women, pregnant women who are at low risk. Trying to get timely postpartum care, which is very key, not only for the care that's happening at the time, but for their future health. Finally, Advantage Dental Services is both a combo payer and partner in our last grantee, looking at dental health with children and pregnant women on Medicaid in multiple rural counties in Oregon, compared to pregnant women and children with commercial insurance in terms of access to dental care. So I'll stop there, and happy to talk more either during the Q&A or afterwards with details.
Good morning. I want to give credit to Maggie Alegria from Harvard, who's the lead author on this paper. She couldn't be here this morning, but she and I are happy to be the token mental health people in this issue of health affairs. As many of you probably know, 1 in 20 Americans suffers from a mental health problem each year, and one in 5 Americans suffers from a mental health problem, and 1 in 20 suffers from a mental health problem that's so severe that they're disabled by it. So 1 in 5 Americans, 1 in 20 who are disabled by it. There are lots of randomized controlled trials looking at interventions for these folks, not many looking at social determinants. And so what Maggie and I decided to do was to use a technique developed by Naiwa Dewan at Columbia to simulate improvements in social determinants to see if they would have an impact on people's mental health problems. So we started with 2 large samples, one the NIMH psychiatric epidemiology studies that Ron Kessler headed, and the second, the Social Security Administration's mental health treatment study, which looked at people who were on Social Security disability insurance, and Bill Fry and I headed. We developed simulations by, and this is Maggie and Naiwa's method, but by first using propensity scores to control for age and gender and marital status, and then reweighting the sample in order to assign realistic amounts of education, employment, and income based on studies of those issues to people in the sample. And we did that by ethnic, racial groups. So in other words, non-Latino whites were the reference group, and we compared them to these different minority groups. We reweighted the sample so that people were moved up an educational notch. For example, 30% of the people who were not high school graduates became high school graduates, and so on. And then, having done that, we looked at their mental health and physical health outcomes. I know it's a very complicated method. There are many limitations to doing this kind of study. We really looked at 2 different populations. Maggie's national epidemiology studies, we were looking at people with common mental disorders like anxiety, depression, alcohol abuse. And in our Social Security disability insurance program, we were looking at people with severe disorders like schizophrenia and bipolar disorder. We had slightly different measures, different sample sizes, and of course, these simulations were based on cross-sectional data, so it's very difficult to assign causality to the outcomes. But here first are the results from the epidemiology studies. I can't see them from here, but I hope you can see them from farther back. I think what they show is, first, this is looking at psychiatric symptoms using Kessler's psychiatric distress scale. And you can see that particularly for African Americans, having higher rates of employment reduce their psychiatric symptoms dramatically. This is using the WHO Disability Assessment Scale, days out of role, and you can see here that for all of the groups, but especially for African Americans, having employment made a substantial difference in the number of days of inactivity, but it also had an impact on Asians, non-Latino whites, and the impact on Latinos was not quite significant, but in the same direction. Okay, then switching quickly to the population of people with Social Security disability insurance. Here we did the modeling or simulations by increasing in 10% intervals the people who would have higher education, higher employment, higher income. And what you can see is that increasing education and earnings had little effect on people's mental health status. This is using the short form 12, but increasing their employment had a dramatic impact on their mental health status. Above 30% increases in employment, we get significant differences. And remarkably, we see the same kind of effect on their physical health status, so that increasing their employment has this fairly strong effect on their physical health. Okay, so our conclusions from this are that employment may improve mental health substantially. And that seems to be true for people with common mental disorders like anxiety and depression, and also for people with severe mental disorders like schizophrenia. The effect, by and large, was the same for ethnic and racial minority groups as for non-Latino whites. And we were not able to show, at least in these samples of older adults, that increasing their education level or increasing their income had much of an impact. That's it. Thank you.
Again, I'll kick off with a few questions of my own, Shira, and my apologies on your last name. I wonder, you highlight at the end, but for those who haven't read the paper, this notion of the importance of referral source, I think, is worth expanding on, because it gets to this notion of real integration and timeliness. So I just wondered if you could, I know you had limited time in your presentation, I think that's a topic worth getting a little deeper into.
Right. Thank you. Can you hear me? Yeah. Well, I think, just to kind of, I didn't get a lot of chance of, to really explain what this is like, but really correctional systems are punitive systems, so there's not a real sense of care. All prisons are required to provide health care inside. They're constitutionally mandated, but there's no constitutional mandate to provide linkages of care back to the community. So a lot of dollars are invested in health care inside the prison system, and then people are just released to the community. So really see these exacerbations of health because there is no continuity of care, which we know has been studied well from hospital discharge to the community, for example, that really does improve acute care utilization for people coming from one system to the other. So really, I think as a healthcare entity, people are just released to the community, and there's very little coordination of care. This has been a really interesting issue to watch, though, over the last several years with the Affordable Care Act, because while correctional systems are punitive systems and they're really more focused on the punishment aspect and not on healthcare, with a new tool in their armory, which is the Affordable Care Act or Medicaid, we actually are seeing participation by correctional systems in enrolling people in Medicaid. And so I think sort of thinking about this framework of a win-win, working across sectors, I really do think that the correctional system, should there be investments in these linkages, would be willing to participate participate, and I think would also benefit from people returning to the community, being linked to care, being healthier in the community, because as we know, 2/3 of individuals will return back to the prison system within 3 years. So I hope that answers your question.
Great, thank you. Andy, you set up the discussion about the high burden of housing costs, and certainly the notion that there'd be reduced financial pressure, therefore reduced financial barriers for those who are actually receiving HUD assistance makes sense. Talk a little bit more about the linkage between the housing assistance and insurance, which doesn't follow that same path of causation. Just give us a sense of how that works.
Right. So yeah, that's a great point. That seems clear why getting access to housing assistance and an increase in income would lead to more affordable care. It's not necessarily clear why that would lead to increases in insurance coverage. And in some ways, we don't know the exact correct answer. I would suspect that there are two processes at work. One is that once you've gone to the trouble of navigating the Stygian systems of U.S. Department of Housing and Urban Development, signing up for Medicaid now seems less difficult. Or at least it's somewhat clear that it's a possibility that once you've gotten all of your materials together, navigating one system can transfer over to another. But one thing I think that maybe could be operating, at least for those who are in public housing, is some sort of informational social network effects that living around individuals with some of the same healthcare needs means that information travels more readily, and so individuals who've already gotten access to Medicaid say, hey, you can sign up for this, and this is how you do it, and this is who you might talk to. And so I would imagine that some of both of those processes are at work. Which is more important, I think, is still somewhat unclear.
Scott, we've published, of course, a lot on alternative payment models, and one of the many findings out of that, or one of the many comments people make out of it, is that unless you put significant amounts of dollars at risk around alternative models, busy healthcare systems keep doing what they're doing. And then you told us how much less interest there was in the proposals that were tied to the payment models. I wonder if you could reflect on the relative levels of interest or resistance to those models on the payer side as opposed to on the delivery system side. So it takes both sides to agree to develop an alternative payment model that's built around reducing inequities. Is it that the payers are afraid to put it up? Is it that the providers are afraid to bear the risk, or is it both? I'm just curious what you see.
I think it's probably a bit of both. It's hard for us to know what the payers might be thinking who didn't submit proposals, right? Because we don't know. So we don't know what was sort of holding them back. We do know for the payers that did submit proposals, they were definitely seeing an opportunity there for potentially long-term reduced costs. So, if you take care of disparities and inequities in your patient panel's health, there's going to be less costs in the long run. I think some payers are starting to see that long-term investment as something that's worthwhile, particularly Health First with the Mount Sinai system working to improve the timely postpartum care for high-risk women. They have clearly verbalized this idea that if we can use that postpartum visit and identify other healthcare issues that these women face, whether it's diabetes or hypertension, and can get a handle on that, do some education and outreach and get them into this system, because for many of these women, this is their only contact with the system often. They see a potential significant long-term benefit of reduced costs. So I think there's more work to do to try to figure out some of the answers or the different answers to your question. I think the fact remains that this experimentation is happening now with how we pay for healthcare, and it's a prime opportunity. And if we don't take advantage of it to try to get some answers and try to do this sort of a different approach to incorporating equity into how we pay for care, then it's a lost one.
And Robert, the strong results associated with employment they're striking. They're also, you can sort of make a logical sense that employment is such a core source of self-worth, and that then leads to this cycle of improvement. But the lack of modeling effects, or limited modeling effects associated with income and education, are striking in the other way. And I just wonder if, based on your broader experience and work, not just that went into this paper, I would imagine, given all the social determinants that we've talked about, that improving on income and education would have a noticeable effect here. So what are we to make of the non-finding on that side relative to the employment side?
Right. Well, education may have a much more profound effect on younger people, and we were sampling adults. The income effect, though, I think is really important. People with psychiatric problems, and I think this is true for other people who become disabled by chronic illness, living on a fixed government income is being consigned to a life of poverty, a life of inactivity, a life of unemployment. And we have lots of data to show that going from employment to unemployment increases the rate of family problems, psychiatric problems, alcohol and drug problems, and so on and so on. Giving people an income is not the answer. Giving them a life is the answer. So we're now engaged in a larger project with the Social Security Administration aiming at people who are in their first application for disability, trying to offer them an alternative of good mental health services and good vocational services, because we know we can get these folks back to work, and we know we can improve their mental health status. And a life of employment is just very different from a life of unemployment and being disabled.
Thank you. We have time for some questions in the audience. I see someone in the very back. If we could, again, get a microphone and identify yourself, and we'll pick you up next.
Thank you. I'm Eva Powell with Common Purpose Health, and I'm curious what the mechanisms used in the studies of the marriage of the delivery and payment reform were for incorporating health equity. Was it mainly a quality measure gateway of reaching a certain platform or plateau of improvement, or how was that actually incorporated in the three that you highlighted?
Yeah, so the payment mechanisms, the models we used are nothing, so there's nothing new or different about those models. So they're using incentive-based models, relative value unit productivity and process of care incentives. Two of them are team-based incentives, looking at incentivizing not only the actual providers or physicians, but looking at nurses, even front staff, reception, administrative staff, IT staff, everybody pulling together as a team to know what role they play in equity. Incentivizing everybody's action around being aware that it's a problem. I think that there's nothing sort of new or magic about the financial models that are being used. It's where they're being targeted, those incentives. And so I think that's the key. One of the sort of side benefits that I think might be playing a role, and I think it's something to think about in terms of either how we pay for care or just how we do care, is we're hearing anecdotally, and so this is all very early, so I can't say that this is a firm finding, but we're getting a lot of stories from these frontline healthcare teams saying, oh my gosh, just being able to see the data of, like, we have disparities between our Hispanic population and our non-Hispanic populations around these healthcare issues. For example, with Fairfax County, Virginia, those 3 safety net clinics, and just being able to see the numbers, and then being able to see, oh, we can nudge those numbers, we can close that disparity or start to narrow it. Even that is just incredibly motivating for them.
Over here, and then we'll be at one in the center, and I think we'll be out of time at that point.
Thanks. I'll try to be brief. Donna Christensen, former member of Congress, and I used to chair the Health Brain Trust for the Congressional Black Caucus. I just wanted to share a model because we wrestled with how to deal with how to address the social determinants. And so we modeled something based on the empowerment zones called health empowerment zones, where communities would come together, identify their major health challenges and strategies to address them, and they would have priority access to programs, whether it was in health or housing or SBA, commerce, economic development. They would have priority to some of those programs in the different agencies. As Dr. Wolf said, sometimes states can do these easier. Maryland did adopt it, and they have 5 health empowerment zones. I'm not sure how they're working, but it was an example of bringing all sectors together, and the states did take it up.
Thank you. Right here in the center.
Good morning, Uche Uchendu. I'm Chief Officer for Health Equity at the Department of Veterans Affairs. My question is for Dr. Robert Drake. You mentioned with regards to the simulation that there was improvement specifically on the people who got employed. But my question is, in the simulation, did you see any decrease in the differences between the reference and the non-reference group?
They were pretty much the same trajectories for all of the groups. And that's what we've seen in studies of supported employment as well. African Americans and Latino Americans who've been studied pretty extensively in that area improve on the same kind of pattern as non-Latino whites. We don't have as many studies, or we don't have as much data for Asian Americans.
And we have one last, also right here in the center.
Marilee, Modern Healthcare. I wanted to ask Andrew Fenelon, what about people aging into Medicare? Did you control for that when you were looking at, because obviously there's a lot of senior housing.
Yeah, so I guess I maybe should have specified, but anyone over 65 is dropped out, and as is anyone receiving SSI who also would have access to Medicare. And we did that precisely for that reason, that, yeah, clearly most older people don't need housing to get access to healthcare.
Please join me in thanking this panel for keeping us. We're slated for a 10-minute break. I really am going to keep it to that because we have 2 more panels that are going to focus much more inside the healthcare system when we come back. Our last 2 panels today focus much more inside the healthcare sector. Excuse me, as we noted at the outset, the origins of much of the research in disparities come from research inside the healthcare sector. As Joe mentioned to us this morning, there's still a tremendous amount of work to be done inside, even as we broaden the lens to look outside. And so we have a panel that did work directly on showing evidence related to the degree of inequity within the healthcare system, as well as the next panel, which will look at some policy approaches and programmatic approaches that were designed to address those disparities. We're going to hear from Winta Metzen, general surgery resident at the Massachusetts General Hospital and a research fellow in the Department of Health Policy at the Harvard School of Public Health. Will Sparrow, a doctoral student in the Department of Health Policy and Management at the Yale School of Public Health, and Renee Shaw, professor of emergency medicine and director of The Place, which is the policy lab for acute care and emergencies in the Department of Emergency Medicine at the University of California, San Francisco. I'll turn it over first to Winta.
Good morning. So I'm going to just say thanks to my co-authors at the School of Public Health under the work of Ashish Jha, and Jose Figueroa is also a co-author here today, John Orav and Jay Zhang. So as we've heard a lot of about today, disparities in care in the U.S. are pervasive, and the IOM report really launched the unveiling of extensive disparities, and surgical care is really no exception to that. In fact, surgical care obviously encompasses a spectrum of healthcare delivery, and actually our focus was just on mortality following surgery. So many of you might know this already, but race is independently a predictor of worse outcomes following surgery. Black patients are found to have up to 30 to 50% higher rates of mortality compared to their white counterparts. And this is really independent of disease severity. It's independent of socioeconomic status. In fact, there have been prior studies that have shown that Black patients tend to have their surgical care at lower quality hospitals, and that a bunch of their care is actually segregated. So there was really a lot of studies that were showing disparities in surgical mortality across the spectrum of procedures, and these studies were mainly in the 90s and early 2000s. And in the last 20 years, since a lot of the disparities were unveiled, there's been a lot going on actually in improving surgical quality overall. In fact, we have really strong national registries. The American College of Surgeons launched NSQIP in the early 2000s. The Society of Cardiac Surgeons also collects data on surgical outcomes, and in fact, in some states, cardiac surgery mortality rates are actually publicly reported and available for providers and patients to use for benchmarking purposes. And with the advent of the Affordable Care Act, actually, with all these alternative payment models, there has been a lot more transparency surrounding surgical outcomes, and they're actually being linked to payment strategies. And even Hospital Compare has been launched that allows us to look at hospital rates of surgical adverse events and actually surgical complications. And so we're really working to empower our patients, to empower each other to understand how to improve surgical quality, yet most of this work has not really been disparity specific. And so with surgery, again, fee-for-service reform is also changing the way that we look at surgical provision in the United States. And we were looking at high volume centers for high-risk surgery, and there's been some prior work that has shown that trends in operative mortality are actually improving, and that when we tend to regionalize some high-risk surgeries at high volume centers, we're actually showing that mortality rates are improving, and that's explains some of the variation. So really fueled by all this interesting research, we wanted to understand disparities in surgical mortality and really move beyond the cross-sectional analyses and look at the trends over time and see if we're actually making any headway. So our study had three main objectives. We wanted to look at 30-day surgical mortality for Black and white patients, understand whether the gap that we've seen previously is actually narrowed, and then to really get at whether this is a function of hospitals getting better over time or actually patients going to higher quality hospitals. We really looked at whether this trend over time was a function of between hospital improvement, meaning that patients are actually going to higher quality centers, or if it's that the hospitals are actually getting better over time and implementing strategies within their delivery mechanisms. And so we also wanted to know who has improved the most for the mortality rate of Black patients, like what types of hospitals. Are they small, are they large, are they teaching, are they urban? We wanted to kind of understand that a little bit better. So we looked at Medicare fee-for-service data and looked at Black and white patients across 8 inpatient procedures. So we looked at a complex, a wide variety of procedures. We looked at heart and lung surgery, we looked at colon and hip surgery, and we also looked at more simple procedures like removing your gallbladder and your appendix, as well as knee repairs. And our motivation there was to really understand the mechanisms a little bit better and look at a spectrum of operative complexity. So our primary outcome measure was 30-day mortality. And again, we wanted to look at the risk difference between Black and white patients. And we risk adjusted for patient comorbidity profiles, socioeconomic status, the type of surgery it was, and then again looked at whether this was a function of hospitals getting better over time or actually patients shifting to better hospitals. So our primary finding was that actually there was an initial disparity gap between Black and white patients, and this is again looking at all procedures in composite. We also looked at procedure-specific trends, but this is 5 minutes, so we'll keep it kind of overview. And we found that basically the rates of reduction for black patients and white patients have improved actually over the last decade. So for black patients by 0.1% per year over the study period, and for white patients by 0.07% per year. And we found that all of this improvement was actually within hospitals. It wasn't a function of actually patients shifting to better hospitals. And in terms of the types of hospitals that had the greatest improvements for the mortality rates of black patients, there were actually small and medium-sized hospitals located in the north, east, and west as compared to the south. And actually, non-minority serving hospitals tended to be more likely to have the largest improvements. And minority serving hospitals tend to see a large volume of minority patients. And so this had really interesting policy ramifications for us as, you know, it's good news, but I don't want to inspire complacency, right? There's a lot of disparity that still exists. And the improvements are occurring within hospitals, which has ramifications from a policy perspective in terms of regionalization of care not being a mechanism of disparity reduction. And then lastly, in terms of, we basically didn't try to eliminate disparities specifically, but overall just tried to improve the quality of surgical care delivery with a host of kind of national efforts. And now someone asked me, well, does that mean that we can just continue kind of doing that without a specific disparity agenda? And I don't think that's actually a good suggestion. I think that there are still disparities that exist, and we saw that in our overall composite slide. And there actually are still disparities that exist in certain subsets of hospitals, such as hospitals that are predominantly minority serving, as well as in certain conditions, we found that for some of the low risk conditions, actually, there were still significant disparities that existed. So I do think there is a need for a disparity specific agenda and approach, and I think that they should be part of reform payment mechanisms, and they should be direct targets of our quality improvement incentives. And I don't think that just being broad with our approach is the best idea. But we have made some progress, and I think there's room for more. Thanks very much.
Good morning. I'm Will Shapiro. I'm very pleased to be here today to share our work on behalf of my co-authors. I should start with an aside that I think this is a wonderful event for bridging the gap between research and practice, and I hope other journals follow this model in their work. So I'm sure everyone here is broadly familiar with the fairly significant consensus in the research literature, including a number of seminal reports from the National Academy of Medicine that have made clear that minority populations in the United States tend to receive lower amounts of effective care relative to white populations. Effective care being care that's almost always clinically indicated and that has high benefit, so an aspirin in the context of heart attack or flu shots among the elderly. We don't know a whole lot about the extent to which this sort of disparity extends to the receipt of low-value care. So this is clinically non-indicated care that exposes patients to potential harm and is also economically inefficient. So to the extent that we believe estimates that 30% of healthcare spending is wasteful, broadly reducing the prevalence of low-value care, I think, has much economic appeal because of the opportunity to both decrease costs while improving quality. So trying to understand disparities in the prevalence of low-value care has only become possible in recent years due to efforts by the U.S. Preventive Services Task Force, the Choosing Wisely initiative of the American Board of Internal Medicine Foundation, and other efforts to really build consensus on what services, tests, and treatments constitute low-value care. So in prior work, we used Medicare claims data to look at the prevalence of low-value care in the 306 hospital referral regions across the United States. And so in this map, the regions that are darker in color tended to have a higher prevalence of low-value care, broadly speaking. And we looked at the characteristics of those regions with higher prevalence of low-value care. And those regions tended to have higher amounts of Medicare spending per capita, a higher ratio of specialist to primary care physicians, and related to the work I'm sharing with you today, a higher proportion of Black and Hispanic beneficiaries relative to white beneficiaries. And so this was looking regionally at trends in low-value care, but in the study that came out in Health Affairs yesterday, we were asking the question of what happens at the individual level. To what extent do individual Black and Hispanic Medicare beneficiaries receive more or less low-value care than white beneficiaries? So the key takeaway is in this figure, which may be hard to read from the back, but we developed algorithms to measure the prevalence of low-value care across 11 discrete tests and treatments. And we calculated the odds of receiving low-value care for Black and Hispanic beneficiaries relative to white beneficiaries. And so that's shown in this graphic, where the odds of receiving low-value care for Black relative to white beneficiaries is in green, and the odds of receiving low-value care for Hispanic versus white beneficiaries is in purple. Dots to the right of the vertical line indicate that Black and Hispanic beneficiaries receive more low-value care relative to whites for that specific service. Now, we attempted to ensure we were actually measuring differences associated with race and ethnicity by controlling for a number of individual level patient characteristics. That includes age and sex, disability status, Medicaid enrollment, a risk score encapsulating how sick the individual is given their chronic conditions, and access to the healthcare system, and we proxied for that using how much the patient used the healthcare system, how many physician visits they had. Importantly, we estimated our models using hospital referral region fixed effects. So we were effectively estimating the odds of Black and Hispanic beneficiaries receiving low-value care relative to whites within a given region in which the population and healthcare system are reasonably homogeneous, and then aggregating that across the country. So overall, we found that low-value care was significantly higher for 5 of our 11 services among Black beneficiaries and for 6 of 11 among Hispanic beneficiaries. Now, we conducted, I think, an important secondary analysis in which we looked at the effect of access to the healthcare system. So number of physician visits on whether Blacks and Hispanics receive more low-value care relative to whites. And we found in some cases that increased use of the healthcare system led to more low-value care for minority populations relative to whites. And I think this is has important implications. So to the extent that in previous work, the fact that minority populations receive less effective care than whites has been partially attributed to difficulties accessing the healthcare system. And then if we want to improve receipt of effective care for minority populations, we should increase access. This suggests that in increasing access, we might also increase exposure to low-value care for Black and Hispanic populations relative to whites. And we refer to this as sort of a catch-22 or double jeopardy, that in increasing access, we might increase receipt of effective care, but also potentially, for some services, increase exposure to low-value care. So I think from an implication standpoint, this would suggest that increasing access is a necessary but not sufficient step, and that we need to think about quality variations both within and across institutions. I think, and more broadly in terms of policy implications, CMS and other payers are beginning to think about measurement of low-value care and measurement of disparities and tying that measurement to payment reform and payment incentives. I think this study begs the question of whether we should also be thinking about measuring disparities in low-value care and suggests perhaps experimenting with new quality incentive regimes where we tie payment to these sorts of quality measures. Thanks so much, and I'm happy to take questions either during the Q&A or afterward.
Good morning. Thank you so much for being here and for taking the time to come together and think about how we can create health systems that at their core prioritize health equity. I'd first like to thank and recognize my co-authors, Drs. Yuchu Shen and Nandita Sarkar, who are at the Naval Postgraduate School, and also the funders of this work, the National Heart, Lung, and Blood Institute and the American Heart Association. So, sorry about that. First off, to give you some context, ambulance diversion is what happens when your nearest emergency department is too full to take incoming ambulances. So imagine you're at a grocery checkout stand and the line's way too long. You self-adjust and go to the next aisle or the next line. This actually happens in healthcare too. When the emergency department's too full, the health system tries to take you to the next emergency department. The problem is that the next checkout line is at least several miles away. And second, the items in your grocery cart, your organs, have an expiration date of a few minutes to a few hours. So you can imagine that it's a fairly precarious situation. Now, ambulance diversion's been around for a long time, but it was originally supposed to be used only for emergency situations. But we know actually that it's been increasing, and even a national report a decade ago showed us that there's one ambulance being diverted every minute. So by the end of this press conference, there will have been 240 ambulances diverted in the United States. Now, as someone who's been working clinically in these systems as an emergency physician and studying these as a researcher for the past 15 years, I started to wonder, while this system dysfunction is not good for anyone, is it possible that this type of system dysfunction affects vulnerable populations, particularly minority populations, worse than others? And so our previous panelists have done a great job of documenting how, on many counts, disparities have been on the rise. Our question was, if we can control for as many social and economic determinants, as well as control for the actual receipt of health care, which is the somewhat unique finding aspect of this study, then we still find that disparities persist, we might be able to have some more compelling evidence that the way we deliver health care, and in fact, the way this healthcare system is structured, may need to be fundamentally changed to address equity. So we decided to study heart attack patients in the state of California to determine if Black and white patients experiencing the same amount of emergency department crowding had different outcomes. What we used is the California statewide data to look at all heart attack patients from a 10-year period from 2001 to 2011. And we took these patient records and linked it with vital statistics so we could determine their out-of-hospital mortality. We also linked it with hospital data so we could look at bedside ownership, things like whether they were private or non-for-profit. And also, importantly, we wanted to control for whether each hospital had access to cardiac technology. We know that Blacks tend to go to hospitals that have lower amounts of technology, and we wanted to control for that. So we looked at things like coronary ICU capability. We looked at the ability to perform cardiac surgery and cardiac catheterization labs. We also were able to obtain ambulance diversion logs, which tell us which hospitals were on divert minute by which day. And we obtained this for about 88% of the state population. And we also linked each patient residence with Google Maps to look at their nearest ED emergency department and calculate their driving times. With this, we had a final data set of over 91,000 patients over this 10-year period. What are our findings? First, we found that while the general trend of diversion has been decreasing over time, and this is likely because of diversion bans that have been placed in many counties across California, you can see that patients who were admitted to Black serving hospitals, the light purple line on the top, consistently across almost all months had more exposure to diversion than patients who were admitted to non-Black serving hospitals. In our multivariate analyses, you can see that longer exposure to diversion was particularly worse for Black patients compared with whites. So if you look at the highlighted cells, the way we would interpret this is a Black patient, for example, who was exposed to medium diversion, which we defined as 6 to 12 hours of diversion per day. Low was less than 6 and high was greater than 12 hours per day. You can see that there's a 3.1 percentage point increase in their 90-day death compared to a white patient. So this is experiencing the same amount of diversion. Similarly, for a patient experiencing medium diversion, they had a 4.1 percentage point increase in their 1-year mortality compared to a white patient. Now, I put the base rate here for you to compare so you can get some perspective of just how big a deal this is. A 3.1 percentage point increase on a base rate of 15% is actually a 21% increase in death compared to a white patient. And a 4.1 percentage point increase represents a 19% increase of Blacks greater than whites. So overall, we found that Blacks, at least in California, experience a double burden of emergency department crowding, meaning that not only do they experience more crowding than white patients, but even when they experience crowding at the same level, their outcomes are worse. Now, what can explain this and what can we do about it? I think it's important to remember that we did control for their access to cardiac technology. This is not explained by the fact that Blacks tend to go to hospitals that have lower or fewer resources. We also controlled for their receipt of treatment. So in cardiac care, we tend to look at cardiac catheterization, whether they receive stents or a cath, and also thrombolytics, whether they received IV drugs that basically bust the clot. We controlled for those things, and we still found that Blacks had a higher likelihood of death. And so our findings point to the reason why Blacks most likely have a higher likelihood of death is because of potentially unmeasured processes of care that we weren't able to capture in our study. So for example, delayed administration of aspirin may not kill you right away. It may not explain an in-hospital mortality increase, but could result in poorer heart function over time and lead to 90-day and 1-year increased risks of death. We also found that under diversion, Black patients tended to go disproportionately more to Black-serving hospitals. As we've seen from Winna's study, that there have been improvements in Black-serving hospitals, but overall there's evidence showing that in general, Black-serving hospitals tend to have poorer care. And so what we find is under conditions of emergency department crowding, minorities disproportionately feel the squeeze. What are the policy implications from this? I think we already have good evidence and robust evidence showing that our current system of distribution of healthcare services, when it's left up to the market, is not equity-based, nor is it equity-producing, and therefore warrants reconsideration. Our findings suggest targeting interventions toward crowding to decrease crowding in minority communities, and that could come from local initiatives or federal ones like directed spending. On a deeper level, our findings could be interpreted to say that allocation of healthcare supply, specifically basic emergency services, needs to be more closely aligned with demand, and that might require governmental intervention. There's more specific policies that I could talk about, but please find me later to talk about them since we're out of time. But I want to just close by saying that while we're studying these issues on a macro level, these data actually reflect the experiences of patients who on a daily basis cannot access the benefits of the healthcare system as easily as others. And we have the opportunity, and I think the moral and economic grounds to show that we should consistently, powerfully, and strategically advocate for a healthcare system where the scaffolding itself is rooted in equity. I'm grateful to be here, and I want to thank you for your time, attention, and as Joachim said, the most precious commodity is your care.
I just want to warn you that all three of my questions are unfair. They're trying to ask you to go a little bit below the data, which I realize is hard to do, but I want to see if I can get a little bit there. So, Winta, you're finding that most of the improvement is most of the disparity reduction is within facility, and then the finding that most of that is primarily non-minority serving hospitals. Forgive this rough cut, but I'm going to assume that non-minority serving hospitals are probably disproportionately less likely to have taken equity-focused interventions than ones that have a larger minority population, because just if you're thinking about your normal course of business, that's not going to be your top priority. So how is it that facilities that are probably not taking an equity focus to their work are still experiencing these reductions in disparities? I mean, how does a non-equity focused intervention yield an equity improving outcome?
Sure. I think if you're held accountable to your outcomes, I think you will be challenged to improve outcomes for all of your patients. I could play devil's advocate and say that there is also the reverse is also true. If you're held accountable to your outcomes, you may skimp on the patients who have risk of actually doing poorly. And we actually didn't find that. I mean, you can't capture that fully by our data. But I do think that the quality environment in surgery has definitely been heightened in the last 2 years. And I do think that with NSQIP being really expanded on and the college actually encouraging benchmarking, I think there is a movement towards performance measurement and performance transparency. I mean, in certain hospitals, there are transparency measurements around performance. I know that there was a hospital that I visited out in Texas actually that looked at surgical performance for all their providers and actually made that transparent to all other providers within the system. So I think there's an overall quality engagement culture that's happening in surgery that is encouraging everyone to try to do better for their patients.
Thank you. Well, the push I'm going to give is you show these disparities in 5 out of 11, 6 out of 11. I'm trying to look at within those 5 or 6, or I should say the 5 that are, the 6 that aren't, there are some patterns that I don't know what they mean, and I wonder if you can help. So for example, for people with dementia, lower risk of low value care when it comes to antipsychotics if you're Hispanic or Black, higher risk of feeding tube if you're Hispanic or Black. Similarly, some differences across imaging and the like. So it's not an all or nothing situation. You're finding higher incidence of low value care in some areas, lower in other. How do we what's the next step in understanding those differences?
So I think it's a great question, and I think highlights an important limitation of our study, which is that we focus on 11 select measures. This is a snapshot of healthcare utilization faced by this Medicare population. And so I think drawing strong inferences from the types of procedures we see moving in one direction or another can be difficult and potentially dangerous. I do think there are a few important takeaways that can be made from sort of broad trends we see. So number one is that for the most part, the measures move together. So with 2 exceptions, when Black and Hispanic beneficiaries receive more low value care relative to whites, it occurs again in both races and ethnicities relative to whites. And so that would suggest sort of the same form of care relative to whites irrespective of race or ethnicity. And so that would suggest perhaps it's more of an organizational issue than an individual provider issue. But I think in terms of next steps, broadly speaking, further investigating what Winta spoke about in terms of whether this is a between or within phenomenon is very important. So in our analysis, we were looking within a region. Regions tend to be fairly homogeneous, but there's also a lot of quality difference among providers within a region. We're not quite powered from it, but I think in future work we'd love to extend this to looking at the extent to which Blacks and Hispanics receive more low-value care within a given organization for certain measures, like an outpatient provider organization. But I think moving forward to sort of thinking about measuring and testing these across a broader array of services will be very important.
Renee, you noted the significant decline in diversion, and given the disparities you show in outcomes when there's a high level of diversion, you could say this is good news because we're reducing this event that creates a disparity. But I'm curious about what we know about what has been done to reduce diversion. One option is what you suggested at the end, which is we better allocate supply to match demand. There are other possible changes that could be made that could actually be very quality detrimental from a perspective of quality or detrimental from the perspective of equity. So I guess I'm asking about the non-measured side of this. Are we replacing a problem with diversion that creates inequities with a different source of inequity, or are we actually closing the gap by reducing the rate of diversion?
One thing I want to be clear about is that when we talk about reducing rates of diversion and the policy initiatives that have been done around that, it's really important to remember that diversion bans in and of themselves, when they're not coupled with hospital-wide measures to decrease ED crowding, is just basically a Band-Aid. You can't have a diversion ban and say no one's allowed to divert because you're still going to have crowding. Diversion for us is a proxy for emergency department crowding, and so diversion bans need to be implemented as a hospital-wide initiative. There's a lot of strategies that have been documented. Eugene Litvak from Boston has done a lot of work in terms of surgical smoothing schedules. This means that, you know, surgeons basically want to have all their surgeries Monday to Friday, and so you save beds on Sunday night for them so their elective patients can come into the hospital. That's something that, you know, is good for their schedules, but it's not great for crowding issues. And so how do you make the hospital move and flow in a way that's more dynamic and not just based on kind of more traditional measures of how we want to provide care or what's convenient for people's schedules? So maybe it's not answering your question directly, but I think we want to target these interventions specifically in minority hospitals, but everywhere, because I think the other important issue is that we can't be efficient if we're not equitable, particularly in emergency services, because we aren't contained. If one hospital is crowded, it goes into another hospital and it affects everybody. So I think this is one really good example of how we can't just sit comfortably and say that, oh, it's too bad that that's happening over there, because it eventually goes down and has this effect on everyone.
We have time for a few questions from the audience. Yes, over here.
I'm Dr. Sarah Lamarck, and I want to thank you for your excellent presentations. I'm the former senior medical advisor at the HHS Office of Women's Health, and we've talked a lot about racial inequities, but I want to also move towards the subpopulation demographics of looking at the impact of sex and gender. Certainly we see it in ERs for diagnosis of cardiovascular disease, we see it in surgical mortality, and we certainly see it for access to care.
I think this is a really important question that deserves more research. I mean, in some ways, we already have a lot of research documenting this, and so we want to move towards how we push health systems towards changing these policies, and that's why I think these types of forums are really good, because we can think together with researchers and practitioners and people who are doing work in this innovation to think about how we can get there.
Yeah, please.
I think this is a really pertinent question, and I think our group is actually looking at some implicit bias studies to look at how our interface with patients is and how gender plays a role in that, both from a provider and patient level. So I do think it's a very important question that needs further work.
I'll just give a comment as the editor, and Paula at the very beginning of today talked about the broadening sense as we move from disparities to equity. Our call for abstracts was quite broad. There's no other way to say it. The majority of papers that came in and that make it through a peer review process are focused on race, ethnicity. There's a tremendous interest on our part, and we are actually putting together another issue as we make a harder push to try to get other dimensions of equity included in the literature. But the fact is, the history of funding, the building up of data sets, the pipeline of research is wider in the race ethnicity area, but that's just from an editorial perspective. I want you to know that our desire is to take a broader look. One more in the back, and then we'll move to our last panel. Yes.
Hi, thank you so much for coming today. My name is Samuel Park. I'm at the Center on Budget and Policy Priorities. My question, I guess, perhaps is more relevant for this panel, given that there are mostly women of color on it. So my question is, in terms of a broader scope of potential policy navigations, how do you see, I guess, in the future of our ability to create potential policies in terms of health equity when most of our research is done in a downwards approach in a predominantly white field? When we look at, for most research, as a white health as a standard, and we look downwards. So in your research, or in possible research for down the road, where do you see in terms of equity, how do we combine social justice into our research in a more socially conscious way to create, I guess, more of a standard of recognizing privilege within health?
That is a very heavy question. I think we're making progress. It's not perfect. I do think probably stakeholdership engagement is really important, and getting perspectives from across the spectrum. In healthcare, we're making all these statements about patient outcomes, but really what the patient values and whether the patient feels like the healthcare system is able to really be an agency of health for them is also a separate question that I think maybe gets at some of your equity and justice issues. So I think there's definitely a lot more room for improvement. I don't know if I perfectly answered your question, and I do think probably the best way to get at justice and equity is more stakeholder engagement and not having a top-down, academic approach all the time, and really getting into the community and seeing what the community actually feels about the healthcare institutions around them and whether they actually are an agency for health and change.
Okay, thank you. Thanks to our panel. And we have introduce them as they arrive so that we can keep going and have enough time for conversation with all of them. Taylor Melanson is a doctoral student in the Department of Health Policy and Management at Emory University. Donna Washington is a primary care physician, health services researcher at Veterans Affairs, Greater Los Angeles Healthcare System, and also directs the VA Office of Health Equity Quality Enhancement Research Initiative Partnered Evaluation Center and the Women's Health Focused Research Area Lead for HSRD at the Veterans Affairs. Amy Carroll-Scott is Assistant Professor in the Department of Community Health and Prevention at the Drexel Dornsife School of Public Health. I'll turn it over first to Taylor.
Hi, my name is Taylor Melanson. I'm going to talk to you a little bit about the new kidney allocation system. So to understand why you should care about the new kidney allocation system, it's important to understand a little bit about end-stage renal disease, or ESRD. So it's the terminal stage of chronic kidney disease. And once you have ESRD, you essentially need dialysis or a kidney transplant in order to survive. Transplant is the preferred treatment for most patients with ESRD. However, it is not a very straightforward process. There are many steps from getting diagnosed to actually receiving a transplant. First, you have to get a referral to go to a transplant center. You then have to take part in an evaluation, which often takes multiple visits. And then if you're determined to be a suitable candidate, you get put on the wait list, and then ideally a matching kidney becomes available and you get a transplant. Historically, racial disparities have existed impacting Black and Hispanic patients at essentially each stage of this process. Particularly important for my talk today is the fact that Black and Hispanic patients tend to take longer from dialysis start to actually getting on the wait list. And under the old kidney allocation policy, there was no credit given for dialysis time prior to waitlisting. Your waiting time started when you were put on the wait list. And it hugely disadvantaged people who might struggle to get on the wait list. This changed in December 2014 with the implementation of the new allocation system. Waiting time is now calculated from the earliest of dialysis start or waitlisting. So this is very beneficial to people who struggle to get on the wait list, and it's important to note that it's retroactive. So people who are already on the wait list, who had dialysis time prior to waitlisting, they're getting a boost in their priority. Because non-white patients tended to have more dialysis time prior to waitlisting, this change was expected to reduce racial disparities, but there are concerns that since we're going to be giving a lot of priority to this group of very disadvantaged patients, once we clear those patients off the list, racial disparities may come back. Potentially this effect might be positive but short-lived. So here we have the average monthly kidney transplantation rates for the three groups we're looking at, white, Black, and Hispanic patients. You see the vertical dotted line is when the new allocation system was implemented. So prior to that, we see that white patients were transplanted at a significantly higher rate relative to Black and Hispanic patients. However, after the implementation of the new system, those three lines converge. And my co-authors and I did a variety of statistical tests to confirm that what you think you're seeing is what you're seeing. In fact, after the policy, the disparity is not detectable, impacting Blacks or Hispanics. So that's good news. However, I mentioned there's a concern that this might be a short-lived benefit. They're giving a lot of priority to people who had a long time on dialysis, Once we clear them off the list, what's going to happen? So we looked at the average time on dialysis prior to receiving a kidney transplant. And here, the vertical red line marks the implementation of the new system. And you see that among all three racial groups, there's a large spike in the average dialysis time of transplant recipients, which is what we expected because we gave those people a lot more priority. However, we also see that all three groups are trending quite rapidly back towards pre-implementation levels. Now, this is concerning if the priority given to them on the basis of dialysis time is what caused the reduction in racial disparities. There's reason to believe that racial disparities may resurface in the future. So, what can we conclude from this? Immediately following the implementation of the new kidney allocation system, we see increase in the likelihood of Black and Hispanic patients receiving a deceased donor kidney transplant. And in fact, the disparities that we saw prior to this new system are no longer evident. That's great, but we want to remember that living donation is also a concern. Receiving a living donor kidney versus a deceased donor kidney is preferable in almost all ways, and yet the vast majority of living donations are given to white patients. So this policy did address one disparity, but it's not to suggest that there are no more disparities in kidney disease. Further, we need to continue to study this because, as I mentioned, there are trends that suggest disparities may resurface, and the fact that it's a relatively recent policy change suggests that we are probably not at the new equilibrium yet. Finally, I want to bear in mind that increased equity is great, but it does not address the underlying problem, which is that we have far too few kidneys for the people who need them. And so we seem to be doing a bit better of a job allocating them in a more equitable way, but we need to bear in mind policies also need to address the supply. I'd like to thank my co-authors as well as our collaborators at Emory and elsewhere. Thank you very much.
Thanks. My name is Donna Washington. I'm pleased to be here to brief you on work we're conducting in the Department of Veterans Affairs looking at racial and ethnic disparities in healthcare. I used the title slide to squeeze in a little bit of extra text, so the names of my co-authors are not listed here, but I do want to acknowledge my co-authors as well as the Department of Veterans Affairs for funding this work. And a small disclaimer, the views that I'll express today are solely mine and do not necessarily reflect the positions or policies of the Department of Veterans Affairs. So one of the important bits of context for this work is understanding the Department of Veterans Affairs and the financial structure, which is that patients using the VA can use it without paying an annual premium for health care. And so some people have described the VA as a quote-unquote equal access system. What in fact that means is that the financial barriers to receiving health care are reduced. And so conducting this sort of work in the VA really gives us a unique opportunity to move past some of the insurance or financial barriers to look at some of the other aspects that contribute to either low quality care or healthcare disparities for vulnerable populations. So today we'll be talking about racial and ethnic disparities in VA patient-centered medical homes. Patient-centered medical homes have been widely promoted across the United States as a primary care delivery model that achieves better patient outcomes. Medical homes are thought to achieve better outcomes through the delivery of team-based care with expanded access, a focus on continuity, and a focus on coordination of care, as well as alignment of incentives with patient quality and patient safety. In 2010, the VA began nationwide implementation of VA medical homes. The VA annually delivers care to about 6 million veterans, and so implementation involved rolling out the medical home model. In the VA, it's known as the Patient-Aligned Care Team Initiative. It involved rolling this model out to over 900 hospital-based and community-based clinics in which these 6 million veterans receive care. Prior to implementation, in both the broader U.S. environment as well as within the Department of Veterans Affairs, racial and ethnic disparities had been noted in both hypertension control and diabetes control. Hypertension and diabetes are each very important risk factors for cardiovascular disease and for premature death, and so we thought that focusing on control of these issues would be quite relevant to the health of veterans in the broader community. So with this study, we sought to answer the question, can VA medical homes mitigate national racial and ethnic disparities in these clinical conditions? To study the influences on achieving clinical control of hypertension and diabetes, our study included looking at clinical control for over 140,000 veterans with hypertension and close to 80,000 veterans with diabetes using VA care in the 1 year before or in the 4 years after the start of VA implementation of medical homes. So we looked at data for the years 2009 and 2014. What we found is that for both the hypertension and diabetes samples, greater medical home implementation was associated with veterans achieving better control. However, we also found that veterans residing in economically challenged areas experienced worse control, as did veterans under age 65. So what about race ethnicity? Our key finding was that the change from 2009 to 2014 in the percentage of veterans in VA medical homes who achieved clinical control of hypertension and diabetes showed the trends that I'll describe on this slide. The two plots show hypertension control and diabetes control, and each of the lines shows the control in 2009 and 2014 for specific racial and ethnic groups. So starting with the slide on the left, which shows hypertension control, the line on top shows the level of hypertension control for white veterans. The line in the middle shows the level of control for Hispanic or Latino veterans, and the line on the bottom shows the level of control for Black or African American veterans. What's quite apparent from this slide is that the level of hypertension and diabetes control for Hispanic and for African American veterans was lower than that for white veterans. Shifting to the graph for diabetes, we also see the same pattern, that for both Hispanic and African American veterans, the levels of diabetes control were lower than for white veterans. So to reinforce, in both years, we see that control was lower for each of these groups, and that the disparities identified in 2009 persisted in 2014. What's not shown on these slides are our findings from some of the racial-ethnic groups with smaller sample sizes. And in fact, it's important to note that disparities were present in 2014 for American Indian Alaska Natives in both of these measures of control, and they were present for Native Hawaiian and other Pacific Islanders in hypertension control. Now, though we described the persistence of disparities from 2009 to 2014, another important finding was looking at the trend in these disparities. And in fact, what we found that for Hispanics, the hypertension control disparity reduced by 3 percentage points from 2009 to 2014, and that's depicted by the arrows on this slide. So there are several implications on addressing racial and ethnic disparities through patient-centered medical homes. Greater medical home implementation was associated with better hypertension and diabetes control, but most racial ethnic disparities persisted. Therefore, to promote health equity, healthcare innovations such as medical homes should incorporate tailored strategies that account for some of the determinants of racial and ethnic variations in these outcomes. Evaluations of medical homes should monitor outcomes for racial ethnic groups because, after all, if you don't measure or look for disparities, you'll miss the opportunity to address them. And then finally, thinking about this work within the broader context, we think that the implications of these strategies reach far beyond the VA, and in fact, they also apply outside the VA, where racial and ethnic disparities for many outcomes are even greater. Thank you for your attention.
I'm not sure if it's good morning or good afternoon. It is tough to be the last speaker on the last panel, but thank you to those of you who stayed. I'd like to acknowledge in this work my co-authors from Drexel School of Public Health and Urban Health Collaborative, including Rosie Mae Henson here today, and our funder, the Robert Wood Johnson Foundation. And we took a look at what is happening among nonprofit hospitals around health equity. So as many of you know, nonprofit hospitals achieve and sustain their IRS tax-exempt status by proving that they provide community benefit and spending on those community benefits. The Affordable Care Act, as you know, had quite a lot of provisions in it that were about engaging the healthcare system in more prevention strategies that included no-cost prevention services, payment reform, the prevention fund, and the like. And one of the important pieces of this was the Community Health Needs Assessment Requirement, or CHNA, which requires that nonprofit hospitals at least every 3 years conduct a community health needs assessment of the communities that they serve, and that they link this to an implementation strategy based on the needs that they documented. So it's about linking community benefit spending and strategies to those documented needs in the populations that they serve. And so it's a real opportunity for a culture shift to move from just spending community benefits dollars on charity care to perhaps in a continuum a little bit more community-based clinical services, and where we would like to get, I think, with health equity, which has been articulated so well today, to talk about more community building activities, those activities that move more upstream to address those root causes, those social determinants of health. And so we wanted to take a look and see how well hospitals were doing in looking at a health equity lens. So what we did after doing an initial literature review and finding that not many CHNAs had been published in the literature, we wanted to see to what extent urban nonprofit hospitals were incorporating health equity both into their CHNAs and also their implementation strategies. We took a look at the 28 largest health districts in the US, the Big Cities Health Coalition, and looked at the publicly available CHNA reports, which is a requirement of the ACA that it is made publicly available, as well as their implementation strategies, for which there is no public availability requirement. And we searched them. We did a quantitative content analysis, and we wanted to take a look at both use of explicit health equity terms based on Braveman and Gruskin's definitions of health equity. And we wanted to look explicitly because we thought this is implying sort of the value of health equity by explicitly using the terms you see here. But we also wanted to see if they're talking about health equity implicitly by using terms that we commonly associated with health equity, even if they did not use that explicit term themselves. And then based on Braveman and Gruskin's definitions of the core elements of health equity, we wanted to see how much they were talking about the causes of inequities or equities, talking about social disadvantage, social determinants of health, those structural causes, those systems causes of those inequities. And so this slide, if you follow the pathway through our results here, you'll see that in those 28 health coalition districts, which were largely cities and urban counties, there were 179 nonprofit, non-specialty hospitals that we reviewed. Of those, 169 or 94% did have a publicly available CHNA. And we assume that this was because they had, the other 10 had not conducted one. Of those 169, we found that all of them, 100% of them, implicitly mentioned health equity, used those terms that I described in the prior slide. However, we moved down to 65% when we talk about those who were explicitly using the health equity terms. And I should mention, of those 110, only about 15% of them incorporated discussions of those core elements of health equity. So they were using the terms perhaps without some deeper discussion of the causes of those health equities. 76% said their stakeholders said health equity was a priority, moving down to 46% saying that they were considering health equity to be a priority for them. Once we get to the implementation plans, we only found that 63% of that original 179 had publicly available implementation strategies, or 63%. Of those 113, 40% of them mention equity explicitly. So again, using those terms which we see as embracing the value of health equity. However, we only found 10. So 8% of those 113 available implementation strategies, which described health equity strategies explicitly. And these included partnering across systems, including investments in early childhood education, K through 12 public health systems. It also talked about removing the social barriers to healthcare access and prevention, a little bit more clinically, but looking specifically at subgroups that are disadvantaged and have a more difficult time accessing healthcare. So what does this mean? Well, we're encouraged. We think that the ACA has started to create a culture shift. I think it was Alan who had said earlier, talking about it and doing something about it are two different things. I think that's a little bit of the story of the prior slide. But to take a more positive approach to our findings, we would say that they are talking about it. They're starting to document the social inequities that are driving the poor health outcomes, the poor costs that nonprofit hospitals are seeing. That's a big step. And I think that it's showing promise of encouraging health equity strategies. Given our uncertainty about the future of ACA, I think we need to think about protecting and expanding this requirement through other either cost-neutral strategies or CMMI innovation grants or Medicaid waivers, innovations around community-centered medical homes or accountable health communities. And I think we need to focus on minimizing that discrepancy between the hospitals that are recognizing that social inequities are causing the healthcare needs that they're seeing in their communities and the health disparities that they're seeing, and supporting them to be able to do more of these community benefits type strategies that are more upstream. We can make changes to the health benefit reporting requirements. We could be encouraging partnership, and I didn't get into some of the other findings of our study, but we found that hospitals that worked across hospitals and across systems had more robust description of their health equity framing in their CHNA and efforts in their strategies. And so there's a role for partnership across health systems, education and other systems, community stakeholders, local health departments, and data and research partners as well. So investing in building those partnerships and building those capacities so that we can move beyond healthcare. We could think about using those community benefit dollars in a way that's going to make maximum impact. Thanks.
Okay, a couple of quick questions on my part and a few from you, and we'll be out at 12:30 as scheduled. Taylor, just help me with a conceptual issue which you describe in the paper, but I think it's complicated enough it's worth verbalizing, which is if the rates have stabilized in terms of transplantation, how could disparities reemerge? In other words, what's the mechanism by which this is a time-limited phenomenon?
So the concern is that we gave a lot of priority to these most disadvantaged people, the people with the longest dialysis times prior to waitlisting. And the issue is, at some point we're going to run out of those people. Once we get them all transplanted or You know, if they die before getting a transplant, we're not quite sure if the racial disparity was fully solved. It appears to be solved in the short term, but that is largely due to the increased transplantation of these most disadvantaged patients. So I think the idea is that it might come back eventually, but fortunately, we haven't seen that yet.
Okay, thank you. Donna, I've certainly seen literature that suggests that patient-centered medical homes reduce disparities from the broader literature. Your findings raise some questions, and you, in your conclusion, talk about the need to tailor efforts when implementing PACT to disparity reduction. I wonder if you could talk about what that would mean in a practical sense.
Certainly. So thinking about the goals of PACT, or the patient-centered medical home, these initiatives focused on expanded access, it's focused on team-based care, it focused on communication and patient-centered care. And so looking to actually VA research studies that have been either conducted recently or in the field, then there are different studies that looked at tailored approaches or targeted approaches, meaning not just tailoring specific activities for vulnerable populations, but even just focusing it solely on that, that approach different aspects of these PACT goals. So to give an example, thinking about the team-based care, then there's a recent study that looked at incorporating peer mentors into the teams of patients who have diabetes. And actually, though this was more of a generic focused intervention, it improved diabetes care for African American patients. Thinking about communication, patient-centered care as another of the targets of patient-centered medical homes, then there have been a number of other studies that look to try to understand what the nature of the communication differences were, and found, in fact, that racial minorities disproportionately are affected by some of the constrained communications in provider-patient interactions. And so communication interventions are thought to help. And in fact, those that specifically address cultural sensitivity or other aspects of cultural care are ones that are expected to disproportionately benefit minorities.
Great, thank you. Amy, I just want to tease out what you touched on at the end about the notion of viewing this positively as at least an acknowledgement of the issue, and go all the way back to what Steve said at the beginning about equity being a concern in other fields as well. Mm-hmm. When you look at these community health needs assessments, do you see evidence that the hospitals are looking at linkages, not just to other sectors, but to other efforts that are specifically oriented to trying to reduce inequities?
One of the things that we talk about in the discussion is that the quality of the reports, the quality of the description of the methodology, including the quality of the partnerships that were involved in both creating the CHNA, but also in developing and implementing the implementation strategies, is quite variable. So we're not seeing evidence of this sort of cross-sectoral health in all policies approach that we would like. We know that it's possible. With my own work with hospitals in Philadelphia and in New Haven, I think that there is wonderful potential there for that, and I think even just the CHNA itself can be such a positive tool for providing a lens to the community health needs of the high cost, poor outcome communities that nonprofits hospitals serve, and that community health leaders are looking for that data in order to be able to advocate for these opportunities for partnership or cross-sectoral health and all policies approaches. So the answer is no, we're not seeing it, but we're hopeful that there has been a little bit of a shift, and that shift and sort of a culture that includes using this opportunity for those partnerships and partnerships for this opportunity is a real culture shift that we can see.
Thank you. Time for one or two. I know we're through the morning, but let's see if there's anyone who hasn't, but the microphone is yours.
Mariana, Modern Healthcare. I have a question for Donna Washington. You said that better or greater implementation of the medical homes did have improvement, but your chart showed that whites and blacks had decreasing control in both diseases over the period of time. So the 3 percentage point gain that Hispanics had was 2% percentage points improvement and 1 percentage point decline from the whites. So could you explain why you're saying that everybody did better when it looks like almost everybody did worse?
Sure, let me clarify that's a great question, thank you. Let me clarify my comments. So what we did was to first look at within sort of across the population, when you look at the degree of implementation of the patient-centered medical home, we used a validated measure called the PACT Implementation Progress Tool, which looked at the degree to which healthcare systems across the VA had implemented each of the different 8 domains of PACT. And what we found, looking just cross-sectionally, that the sites that had greater implementation had better outcomes than the sites with worse implementation. I mean, this was really just one step that replicated a much larger study conducted by people who are tasked with evaluating patient-centered medical home that displayed that. So within 1 year of data, for example, then we found that. Looking across time, of course, as you pointed out, the results decreased, and we think there are reasons for that. First of all, both in that earlier patient-centered medical home research as well as in the literature elsewhere, we see that higher numbers of patients are associated with worse outcomes. And in fact, over the time of our study from 2009 to 2014, the number of patients using the VA increased by 700,000. That's like taking a whole healthcare system and adding it on to another healthcare system. I mean, we suspect that part of that reflected the economy and the people taking advantage of the safety net role of the VA. But what we think happened is that perhaps these beneficial effects of the patient-centered medical homes were overwhelmed then by these increased numbers. And then the other thing that it's important to think about is the context. So when we step outside of looking at what happened within the VA and compare our results to some of the findings from the broader US environment, for example, looking at HEDIS measures over the time frame, we see that there was something else going on, because at least in blood pressure control, then you can see that in commercial plans, the HEDIS results show that control also decreased somewhat.
One last question, yes, from the VA.
Hi, it's a comment, and following up on what Dr. Donna Washington had just discussed, I wanted to comment also that I seem to see a reluctance with people admitting that maybe something got better because people think others might get complacent on the topic, and perhaps doing transparent data in terms of monitoring pre-implementation, during implementation, after implementation, for instance, on the kidney transplant situation, continuing to look at that data will keep the situation informed as far as whether or not it's changing or not. Additionally, the VA study that Dr. Washington has just talked about looked into various breakdowns of race ethnicity down to every group, which is what you don't tend to see a lot of in research, and we're increasing disparity for the groups that we don't routinely measure. Thank you.
Thank you.
Could I make
yes,
a comment on that? Just that I think we need to be evaluating these community health needs assessments and implementation strategies as well, not just the linkage between what needs are found and what implementation strategies are proposed, but what's actually implemented, and then what the outcome is of those. So not just increasing the quality of that effort, but also looking at the impacts of that effort. So thank you for that comment.
Okay, thank you all for joining us. I want to thank our funders that made the issue possible, the Kresge Foundation, the California Endowment, the Aetna Foundation, the Colorado Health Foundation, the Episcopal Health Foundation, the Robert Wood Johnson Foundation. As we bring this session to a close, please join me in thanking our final panelists as well. And we are adjourned.